Welcome. It's plenty of seats still in the room, so make your way forward. Great pleasure to be here. I'm Maurizio Cecconi from Milan in Italy, and a great pleasure to chair this session about sepsis and ARDS future therapies with Alexander Vlaar from Amsterdam. And without losing any more time, we're going to ask the first speaker, also from Amsterdam, Dr. Lieuwe Bos, to join us on stage.
Thank you very much for the invitation. So the topic I got was sepsis and ARDS therapies immunomodulation. So what I'm going to try to do is to convince you in the next 15 minutes that immunomodulation is indeed something we should try, even though we have tried it for the last 20 years, and that we need to try it in a precision medicine environment instead of an unselected patient population. My major conflict of interest is that I am a co-PI in a study that's doing precisely that. So I have a huge intellectual conflict of interest. I'm also going to focus primarily on acute respiratory distress syndrome because I like lungs and because I think the lessons learned in ARDS can be directly applied to sepsis as well. So we all know this image from New England with on the right side a injured alveolus in the ARDS lung. And you can see all of these inflammatory pathways that are activated in the lung of an ARDS patient. And we then started to trial all kinds of anti-inflammatory treatments to try to make the patients recover more quickly. I think it's a useful image for a textbook, but it's also very misleading because there is no single patient that walks through all of these paths towards injury. And I think that fact is forgotten in clinical trials quite frequently. So before talking about how we could settle this, I'm going to tell you about the strategies that have been taken. So when you look at the top of this figure, you see the no enrichment strategy, an unselected patient population going into the trial. And we have largely concluded by now that this is an ineffective strategy. After more than 50 RCTs in unselected populations, not a single one provided any benefit from a pharmacological intervention. Then we tried prognostic enrichment, meaning to select patients that have a higher probability of reaching the primary outcome in the study, so a higher mortality, for example. That worked for some interventions, think about prone positioning and VV ECMO, where all of a sudden the risks and the benefit yielded towards the benefit towards the patient. And in this talk, I'm going to talk about predictive enrichment, meaning to a priori select patients that are more likely to benefit from the intervention per se, without necessarily influencing the baseline risk of the outcome. This is also sometimes called precision medicine, which is maybe a bit of a fancy term to just doing the right thing for the right patient. So if you look to the steps towards going to precision medicine, probably the first step is to discover subphenotypes. Then they need to be recognizable at the bedside. So you need a point of care or at least a rapid test to say this patient falls into this category and this patient falls into another category. That test has to be prospectively validated, and then a randomized controlled trial has to be performed, including such phenotyping approach to allocate patients to one treatment or the other. So there are many different ways to subphenotype patients with ARDS, and in this talk I'm going to focus on the systemic host response, so looking at plasma markers of hyperinflammatory state, for example. And this work has largely been pioneered by Carolyn Calfee from San Francisco, and she already 10 years ago now described two phenotypes in ARDS. I'm going to spend a little bit of time to explain why this is probably more important than many of the other things that we've been looking at in terms of plasma biomarkers. So what she described is a hyperinflammatory phenotype with very high concentrations of markers like IL-6, IL-8, TNF receptor 1, and low values of activated protein C and bicarbonate. The other phenotype she called hypoinflammatory, which is probably a wrong term, but it's less inflammatory than the hyperinflammatory one. These patients fall into distinct categories. So it's not like it's a continuous scale where you move slowly from one to the other, but patients are with like 98% accuracy classified into one of the two categories. So you're either hyperinflammatory or you're hypoinflammatory, and a sort of intermediate state is very uncommon. That's important if you start to think about trial design. So we're now 10 years further, and I know there are a lot of people that say, oh, we still haven't had any prospective validation, we didn't see any inclusion in randomized controlled trials, and that's true, and 10 years is a long time, but we're getting there. So what we do have is now more than 10,000 patients where these phenotypes have been identified, and there has been a consistent difference in mortality between the hypo and hyperinflammatory phenotype in ARDS, in sepsis, and even in pediatric ARDS. And this difference, at least in the adult population, always accounts for about double the mortality in patients with hyperinflammatory compared to hyperinflammatory, and about 1/3 of the patients are hyperinflammatory and about 2/3 are hypoinflammatory, meaning that in the total population, half of the death come from hyperinflammatory patients, half of the death come from hypoinflammatory patients. Of course, this is interesting, so this could be prognostic enrichment, but that's not what we are interested in this talk. How could this influence immune modulation therapy? So what's striking is that in secondary analysis of randomized controlled trials, there were differences in the outcomes between the intervention arm and the control arm, depending on the phenotype the patient was allocated to. So you can see here that the hyperinflammatory phenotype benefited from a high PEEP strategy, a conservative fluid strategy, simvastatin, activated protein C, and in an observational study from steroids. While the hypoinflammatory phenotype was harmed by most of these treatment strategies in secondary analysis of these trials. So this shows that there's effect modification that is consistent throughout studies and might mean that we need to take this baseline risk of the effect of treatment into account when doing a randomized controlled trial. So the second half of this presentation I will spend on the PANTHER trial that is going to answer this question for us. So we now have two phenotypes that have been identified retrospectively in about 10,000 patients. We now have bedside tests that data didn't show you, but there are bedside tests that can identify these patients for you, and you can allocate the patient using a biomarker test that takes less than an hour. And those biomarker tests have now also been validated in a large cohort in the UK. So in PANTHER, the idea is to develop an adaptive platform trial worldwide with all stakeholders involved to start to look for effective immunomodulatory therapies in patients with ARDS. And this trial is now being funded by the NIHR for the UK part of the study, and we're applying for funding in Canada and Europe at the moment. So we're going to look a little bit closer, not at the organizational aspect at the top, and not at the pandemic preparedness aspect at the bottom, but at the trial design that we have chosen for these interventions. Because I think it's really important as clinicians to know that we shouldn't give up on immunomodulation and that there's still hope that this would provide a benefit for our patients. So in this study, patients with ARDS are included. The biomarker test is employed at the bedside. It provides a result in about an hour time based on the plasma cytokine profiles, and the patient is allocated to hypo or hyperinflammatory ARDS. And they serve as strata in the study. So the patients are then randomized within their strata to either a intervention or to usual care. And we'll go through these aspects and how that's important. So first, let's talk about the patients with ARDS, because this has been a changing topic in recent years that's probably really important if you want to mess with the immune system. So we used to only include patients on NIV or invasive mechanical ventilation in the definition of ARDS, but that has recently changed with the global definition where it's now allowed to be on high-flow nasal cannula with more than equal or more than 30 liters of flow. Furthermore, the bilateral opacities can now also be evaluated with lung ultrasound and not only by chest X-ray or CT scans. And eventually it's also possible, if the patient does not have an arterial line, to use the SF ratio instead of the PF ratio. So why is this important? Well, if you look at those inflammatory subphenotypes, so at hyper and hypo-inflammatory ARDS, there is a half-life to them. Patients start with hyperinflammatory states and then gradually move to a more hypo-inflammatory environment. And this is work from Rombout van Amstel together with Pratik Sinha. This is showing in the Mars cohort from Amsterdam, where you can see on the x-axis on the left the days 0, 2, 4, and 30. And you can appreciate that at day 0, about 1/3 of the patients are hyperinflammatory. But there's a half-life to it. After 2 days, it's just 18%, and after 4 days, it's just 9%. You can also appreciate in this figure that the patients that are going on to die are the patients that remain hyperinflammatory. And on the right side, you can see the patients who are hyperinflammatory on the first day or hypoinflammatory in the first day, and then stratified by their state on the second day. And if the patient resolves their lung injury or their hyperinflammatory state, so they go from hyperinflammatory to hypoinflammatory on day 2, they have the same mortality risk as the patient who started out as hypoinflammatory. While if they change towards hyperinflammation, they have the same risk as starting out with hyperinflammation. So it's really important to be there early and to intervene early. That's why such a global definition is of essence for any of these trials, and we cannot just go after patients who are already on day 4 or day 5 of their illness. So then it's also very important what kind of treatments we're going to include, and we haven't set out to decide what treatments are going in. And what I would like to emphasize here is that we all have our pet treatments, right? We're all things that we like. We have like good contact, we have studied something in our preclinical work, but that's not the best reason to include something in the study. So we decided to completely take this out of the executive committee and give all of the power to an independent treatment prioritization committee who just takes the evidence and prioritizes treatments for us. And at the moment, but this can still change, the number 1 on the list is simvastatin because of the post hoc analysis that I've showed you, and the immunomodulators that are still evaluated are the ones shown here, baricitinib, tocilizumab, vilobelimab, and a CD14 inhibitor made by an Australian company that has been trialed in COVID before. So then the next step is, how do we know if the treatments are efficacious or not? And these are done by frequent intermediate analysis based on a Bayesian statistical framework that has organ support-free days at day 28 as the primary endpoint. And we have good evidence from other studies to suggest what kind of effect sizes are to be expected in these kind of studies. And the final goal of this study is not to provide definitive data, but to provide adequate pretest probabilities to do an even larger trial. And we're working in close collaboration with instances like the FDA or EMA, and also with the industry to make sure that everyone's needs are fulfilled in this. So what I've tried to show you is that such a complex framework is probably going to be the way forward to overcome this impasse of 30 years of ineffective treatments with immunomodulatory strategies. And this is specifically for ARDS, but can be extended to other conditions like sepsis. And this is by no means the only trial doing that. There's other initiatives like the TRADE study from Edinburgh that takes a similar approach, subphenotyping the patient. So my take-home message from this is that there are these inflammatory phenotypes. Not taking them into account will probably set you up for ineffective treatments, and maybe this is the way forward, although I recognize that it's just one of the ways of changing or splitting the patient population Because if you look at the ARDS population, you could also look at endothelial dysfunction or epithelial injury or the alveolar host response. And I know there are going to be a lot of talks afterwards about these topics. But even in those topics, it might be important to take the phenotype of the patient into account. And I think we are now entering the age where if you do not do any predictive enrichment, we're setting ourselves up for failure in future studies. Thank you very much for your attention, and happy to take questions.
Thank you for a very nice presentation. The floor is open for questions. We have time for one or two quick questions. If there isn't any, maybe I start. I love your design now to go and look in the future how to look at phenotypes and test new treatments. How can you actually do it in practically? Are you already establishing a large networks of ICUs to be able to spot these phenotypes? And also if you can comment on the fact you explained very nicely that the situation is very dynamic day on day and you want to spot when one patient is moving from one hypo and hyper. How do you actually do that almost in real time?
Yeah, so we are setting up a large network of hospitals and want to be inclusive. So at the moment we have funding for like 50 hospitals in the UK. We're setting up 70 sites in Europe through an EU grant and sites in Canada and the United States through other grants. And the bedside testing, there are now companies working on bedside testing that are even available in the clinic already. So it just takes an hour. We have one in our lab. You can draw the blood, you have to get the plasma from it, and then you get a result within an hour. Or alternatively, you could have the diagnostic at the central laboratory, just like you get a ferritin or something else. You could also get an IL-6 or a TNF receptor.
Thank you very much. We move to the next speaker. The next speaker is Julie Helms from Strasbourg. She will talk about targeting coagulation in sepsis.
Thank you very much for this kind introduction. I'm very happy to be here and to talk to you about targeting coagulation in sepsis. And I hope I will be able to convince you that it is a good pathway for the future. Here are my disclosures. And to begin with, I will first try to show you why DIC is a critical issue. DIC is a critical issue for the first reason that it is a very frequent complication of sepsis. As you all know it, sepsis is due to inadequate host response to infections that will lead to excessive coagulation activation and defective fibrinolysis in this patient. And this will result in DIC in 30 to 40% of the patients with sepsis. And as we have something like nearly 50 million sepsis per year in the world, we probably have something like 20 million DIC each year. The second reason why DIC is a critical issue is that it contributes to multiple organ failure. As you know it, when patients develop symptomatic DIC, they can present bleeding complications, but they are very rare and usually at the end of multiple organ failure. But they mostly develop thrombotic complications. And you can usually see them on fingertips and toes because you have microthrombi on fingertips and toes like you can see here. But you can also imagine that you have this microthrombi also in the microcirculation of all organs, leading to multiple organ failure. And as DIC contributes to multiple organ failure, you can easily understand why it will contribute to mortality rate. In this study, you can see that mortality at 1 year without DIC is 25%. And if you have a DIC, it is 63%. And because it is a very critical issue and frequent issue, it is very important to diagnose DIC. Indeed, so far DIC is not so simple to diagnose. First, because the gold standard is the ISTH score, which I present you here, and which includes several hemostatic global parameters, but you can see that it is not very easy to use at bedside. So the last recommendation, the international recommendation from the ISTH, suggested to use a simplified score, which is called SIC score, including only platelet count and prothrombin time, also with SOFA score. But you all know that SOFA score is always equal or above to 2 points in sepsis, so you can already forget this. And if SIC score is positive, then you should calculate ISTH score. Just to make a precision, when you have an SIC score that is positive, then you can talk about sepsis-induced coagulopathy. If you also have an ISTH score that is positive, then we talk about disseminated intravascular coagulation, or DIC. The main limitation of these diagnosis scores is that they are quite uneasy to use at bedside, and they only allow late diagnosis of DIC. So we have to move forward to new biomarkers, as it was already suggested by the previous talk. But I will not concentrate on this part because I would like to focus the rest of my lecture on diagnosis and treatment of DIC. So once SIC or DIC is diagnosed, we have to do something. And as you know, as most of the patients develop microthrombotic DIC, the main therapeutic options that has been investigated over the past decade are anticoagulant treatments. And you can see some of the targets in this picture. The other option is to restore the deficient fibrinolysis. We will see it later. As far as anticoagulant treatments are concerned, I have summarized some of the anticoagulants that have already been tested over the past decades in very famous trials. You can see that none of the trials reduced mortality rate, but all the trials were associated with an increased risk of bleeding. So far, we have 2 decades of negative trials. However, all these trials suffered from the same flaws. If you look at these trials, patients that were included in the studies are very heterogeneous. They have included patients with a DIC that could benefit from an anticoagulant treatment, but also patients without a DIC. And also, they have included patients on different stages of DIC, patients with thrombotic DIC, but probably also patients with hemorrhagic DIC. So if we try to find solutions for these flaws and to design better clinical trials later, we probably have to find a way to better stratify our patients so that we will include only patients with a DIC. The second point is that we have to identify the good therapeutic window. It's not a good thing to give an anticoagulant treatment to a patient who is bleeding. There is only one clinical trial to have included patients based on the presence of DIC. It is a SCARLET study, which has included sepsis or septic shock patients with a coagulopathy, which was defined by the SIC scores that I have just shown to you. The main outcome of this trial was day 28 mortality. 800 patients were included in this trial, and they compared the efficacy of recombinant human thrombomodulin to a placebo. Unfortunately, this trial is negative on the primary criteria, which is mortality. You can see there is no difference between patients who received thrombomodulin and those who received placebo. However, when they investigated subgroup patients, they have evidence that in patients who still suffer from a coagulopathy at the time they received the treatment had a better outcome when they received thrombomodulin. So maybe thrombomodulin could be effective in these patients. In this trial, it's the first one to have stratified the patients based on the presence of a coagulopathy, but probably it has not really identified the good therapeutic window. We have also performed a post-hoc analysis of the French patients included in the study, because we have included 150 patients out of the 800 in France. And as you can see in these results, it's quite interesting because French patients had a better outcome when they received thrombomodulin. And this is due to two factors. The first one is that patients in France received thrombomodulin earlier than in other countries. And the second point is that we had fewer patients who received concomitant heparin treatment. And you know that heparin is going to inhibit the effect of thrombomodulin. So this is only a post-hoc analysis of a small group of a big clinical trial. However, it probably lays the groundwork for a new clinical trial. Another option for treatment would be to target contact activation, which is also called intrinsic pathway, because the intrinsic pathway plays a critical role in the growth of thrombus, but has no role in physiological hemostasis. So if you inhibit this pathway, you will have an antithrombotic effect, but you will have no hemorrhagic effect. Several new strategies have been developed with this hypothesis, including antisense oligonucleotide to decrease factor 11, including aptamers and antibodies to block factor 11 activation or activity, and also small other molecules. But as I told you, there is probably another pathway that could be treated in this patient, and it is to restore the deficient fibrinolysis, because patients with septic shock-induced DIC have a deficient fibrinolysis, which means that when you have microthrombi that have developed throughout your organism, they will not be fibrinolyzed by this pathway. What kind of therapeutic agents could we use? So far, we don't have so many. The first one is, of course, plasma, because plasma contains a lot of proteins, including fibrinolytic proteins, like plasminogen, for example. The second one is an inhibitor of neutrophil elastase, which could inhibit the degradation of the main protein responsible for fibrinolysis, which is plasminogen. Unfortunately, this treatment is only available so far in Japan, but we are going to run a clinical trial with this treatment. And the third one is plasminogen. That would be the gold standard, the Graal. However, plasminogen is not available, and no laboratory is able to produce it with sufficient quantity so far. So I will show you the results with what we have as a treatment. There are three small studies that have been conducting using plasma therapy or therapeutic plasma exchange. This first one used therapeutic plasma exchange in patients, in 31 patients with septic shock. And as you can see, they have measured global hemostasis markers before and after therapeutic plasma exchange, and you can see that therapeutic plasma exchange reduces imbalance between pro- and anti-inflammatory factors, which is quite what we could expect. There is another small randomized controlled trial, including 112 sepsis-associated DIC patients, which were randomized into three groups. The first one was therapeutic plasma exchange. The second one received low-dose heparin, and the third one was standard of care. And again, you can see that therapeutic plasma exchange was able to improve coagulation function, and these results would be partly due to endothelial protection, and also it was associated with a better outcome in these patients. The last trial is a randomized control trial including 80 children with sepsis or septic shock in non-overt DIC stage, which means that it is a very early stage of DIC. The children received either fresh frozen plasma, unfractionated heparin and tranexamic acid, or standard of care. You can see that the children had a better outcome in the fresh frozen plasma group, and they had less progression toward overt DIC. Finally, we have performed a pilot study, which is not published yet, including 60 patients receiving plasma from octaplasm at day 1 and eventually at day 2. These patients had a septic shock and a sepsis-induced coagulopathy, and by giving them plasma, we were able to restore deficient fibrinolysis. We had also a reduction of mortality, although it was not significant because the trial was not designed to with sufficient power to show this. And we propose that probably we could improve their prognosis with sustained treatment. So as a conclusion, more than half of the patients with septic shock-induced DIC still die despite the treatment of sepsis. So we have to move forward toward new biomarkers and toward new treatments, probably targeting both anticoagulant pathway and fibrinolytic pathway. Thank you for your attention.
Thanks, Julie, for the great overview. Any questions from the floor? So first question, if we had the previous speaker also looking at hyper-hypoinflammatory, and there was also a sub-study to Xycrus activated protein C with these differences. So instead of, because I saw the one slide, negative trials, should we also look back here and see whether there is a potential in this kind of patient populations?
Probably because some of the anticoagulant treatments that have been investigated on the past years, like protein C, activated protein C or thrombomodulin, also have effects on inflammation. So if we were able to establish the phenotype of this patient and stratify them between hyperinflammatory and DIC and hypofibrinolysis, we could target treatment more appropriately.
And one other question, because with the trials you're showing that one of the big side effects is the bleeding risk occurring and probably outweighing then the benefit, and in that way we have negative trials maybe as well. So the difficulties, of course, in this patient population to identify the patient at risk of bleeding with the conventional measurements. So how would you approach that in a clinical setting, or could you improve the trials that way?
I think the risk of bleeding is not the problem in septic shock patients, because septic shock patients have a thrombotic phenotype, and it is only at the very late stage of multiple organ failure, when the patient will die, that he will have hemorrhage manifestation, but usually they don't. However, if we give them anticoagulant treatment, we may have bleeding complications, but that's probably the interest of the intrinsic pathway treatment, because if we can inhibit this pathway, we will have an antithrombotic effect, but we don't take a hemorrhagic risk.
And if I understand, potentially in the future we could look at inflammatory profiles, coagulation profiles to select also which patients would benefit from this. But is there then a biomarker that you could use to look at the efficacy of the treatment? Or again, is it this some of the things that we do like with our point of care testing for coagulation? And I'd just like you to comment on this.
Yes, yeah. That's an interesting question, because we are currently validating a new biomarker on a validation cohort to identify patients with ADIC using a biomarker that is available in routine. So we have the result in 30 to 40 minutes. And it is available whenever you have something to make a machine to make a complete blood count. And we are also validating biomarkers to evaluate the efficacy of the treatment.
Okay, good luck. Thank you.
Thank you.
So it's a pleasure to ask to come on stage our next speaker from Pittsburgh, Dr. Hernando Gomez.
Thank you, Mr. Chairman. Very grateful to be here. Thank you to the organizers for the kind invitation. We'll share with you a little bit of our work in the use of metformin in sepsis today. These are my disclosures. I do have to disclose that bioMérieux has provided all the NephroCheck testing kits for our study for free, and that's my conflict of interest for this talk. So, this work began with some disruptive notions that appeared in the literature, suggesting that what caused organ dysfunction in sepsis was not quite what we thought. And The first thing was that you don't need overt hypoperfusion to get AKI during sepsis or any other organ dysfunction by that matter. And the second thing is that cells really were not dying in these organs. They were just quiescent, kind of shying there from their duty in the kidney. So that led us to, start thinking about other possibilities. And what I'm going to focus today on is essentially how these cells, these tubular epithelial cells, essentially respond to that injury by using their evolutionary conserved mechanisms to try to shy down from injury and protect themselves, and how the perpetuation of that is what may be causing the organ dysfunction in our patients that can be tackled to get them through this speed bump. So we focus on this protein, which is called AMP, activated protein kinase. It is a master regulator of energy, and importantly, is an avid activator of fatty acid oxidation and oxidative phosphorylation. The reason why that's important is because what we've seen is that these tubular epithelial cells usually, in the face of injury, shift their metabolism to glycolysis, which is a normal, natural response to injury. And when they cannot go back to their normal, usual utilization of oxidative phosphorylation is when organ dysfunction persists. So AMPK, essentially by inhibiting the acetyl-CoA's carboxylase, which is the natural repressor of the carnitine palmitoyl transferase 1, stay with me please. This is the gatekeeper of the entry of fatty acid, long-chain fatty acids into the mitochondria, and therefore by releasing this inhibition, AMPK activates fatty acid oxidation in cells. So the first question we asked in the lab, and this is really a translational story that started in the laboratory and now has made it all the way to clinical trialing. We asked, well, if we take away AMPK from the renal tubules of animals and then expose them to sepsis, and we use these quadruple knockout mice, we expose them to doxycycline for 3 weeks, and then all the AMPK in the renal tubules disappears, and then we expose them to sepsis. What is going to happen with AKI? And the expectation and the hypothesis was that AKI was going to be worse. And that's exactly what we found in those animals that did not have AMPK in the renal tubules, because we have knocked them out. They had more severe AKI than animals that did not. We said, all right, what if we inhibit AMPK by giving a medication to these animals? And you see here on the right-hand side panel that there was an increase, a dramatic increase actually in mortality. The next logical question is, well, can we use this to treat these animals and prevent AKI? And we activated AMPK using, in this case, ACAR, which is an AMP analog. And what we found was that we were actually preventing AKI from happening in these animals exposed to cecal ligation and puncture, which is a model of sepsis. And furthermore, we were able to improve survival. And you see here, right here, metformin. And that's what concatenates this with the potential to be used in human beings. This is a way to repurpose a very inexpensive, ready-to-be-used medication. So AMPK is thought to inhibit the complex 1 of mitochondria, and by those means increasing the AMP to ATP ratio, and by that means increases the activation of AMPK. So we went to the literature and we found a couple of meta-analyses that have actually looked at this. And there's many papers actually showing this, and they were overwhelmingly showing that patients that were exposed to metformin and went to the hospital and got septic overwhelmingly did better in terms of survival than patients that were not exposed to metformin. And that was in this meta-analysis by Liang and also in this meta-analysis by Tan. The problem with the meta-analysis is, of course, there was a lot of heterogeneity in the studies. They were comparing diabetic versus non-diabetic patients. So there were some questions, and perhaps they were also not referencing what was happening with actual organ dysfunction, which is what we wanted to understand. So we ran this retrospective study in Pittsburgh where we found essentially diabetic patients, 682 exposed to metformin when they were in the hospital, and 14,000 that were not. And using propensity matching score, we found after a lot of sensitivity analysis, and we tried hard to get this signal to go away, we found essentially that patients that were exposed to metformin and developed sepsis, where that was associated with a decrease in 90-day mortality and a decrease in the development of moderate to severe AKI. So with that, we went to the NIH and said, well, we need to work on this, and I'll tell you what the response was. But there's a couple of things. Every time you tell an intensivist, in particular a nephrologist, that you're going to give metformin to a patient with AKI, they open their eyes and they start sweating. And that's a normal response, I would suggest. But again, there's a lot of data suggesting that the hyperlactatemia that happens even in the context of metformin might actually not be as bad. You see this study by Posma, which is showing in the x-axis the amount of hyperlactatemia that you have from 0 to 25, and then the adjusted hazard ratio of mortality in the y-axis. And if you can see, the blue line is patients exposed to metformin, and the red line is patients exposed to not exposed to metformin. So you can see for whatever level of lactate, if you were exposed to metformin, you'll always be better off. Again, this is not proof that metformin saves you from dying, but it does demonstrate that if you are hyperlactatemic in the context of metformin, that is not the same as the patient that arrives with massive intoxication of metformin, which is the ones that we are so fearful about. The FDA, recognizing that this was not as dangerous in patients with mild to moderate renal dysfunction and in some cardiac dysfunction, decided to actually loosen its regulations on the use of metformin in patients and actually changed the prescription alerts in the medication, making it more available for patients, for instance, with mild to moderate renal dysfunction. But there is a risk of accumulation. If you see this old study, but nevertheless very useful, you see patients here with mild chronic renal dysfunction and moderate renal dysfunction. And if we focus on the population that we're most likely to enroll in sepsis, you see that if you have this renal dysfunction, your half-life of elimination of metformin will go up. This is not rocket science. There is a risk. And we are looking at that very, very closely. So as I told you, we went to the NIH and said, hey, we should probably look at this prospectively because there's nothing retrospective anymore that we can do to resolve this question. And they said yes. So NIDDK, we're thankful for their funding, decided to fund this study. So we launched to do the first step of this, which is to establish safety and feasibility of implementing the use of metformin for the first time in patients with sepsis, to inform, of course, a large multi-center trial. This is a prospective randomized blinded phase 2 placebo-controlled trial, and we are focusing on a population of adult patients, essentially with established enteral axis, within the first 48 hours of fulfilling criteria for sepsis. We included adults admitted to the ICU, as you said, as I told you before, with sepsis 3 criteria and with available enteral axis. I cannot tell you how difficult this has been, but it's okay. I mean, there's enough patients that have overall access that we can use because we don't have intravenous metformin. The only presentation is oral, so we need to use it. The exclusion criteria, I don't want you to read all this. I'll just focus on, we are excluding patients with severe renal dysfunction because of the reasons that I told you. We want to make sure that our patients are safe. Metformin use in the last 30 days, we're excluding these patients essentially because we don't want to contaminate the control arm. And we are, of course, excluding patients that have severe metabolic acidosis, defined as a pH of less than 7.2 with these details. So we are randomizing patients at a 1:1:1 ratio. I'll tell you what that's about in a second. The sample size that we calculated based on the development of what we call metformin serious adverse events, and I'll tell you what that is in a second, is going to be a goal of 80 patients. And the intervention arm, as I said, in the 1:1:1 ratio, is going to be a metformin low dose 500 Q12 for 5 days versus metformin 1 gram Q12 for 5 days versus placebo. As I said, this is a blinded study, so we don't know what we are giving these patients. This is essentially the timeline that we have seen in our patients. We have a 48-hour window of enrollment with a buffer of 6. We are going to give 10 doses in 5 days, and we're going to be monitoring these patients, and we are monitoring these patients with gases, venous or arterial, lactate, and glucose every 12 hours for the first 7 days. So I know better what's going on with the patient than the clinician that is taking care of the patient, which is essentially what we're doing because we want to make sure that our patients are safe. So the primary outcome is metformin associated adverse events. And we define that as either having hyperlactatemia, severe metabolic acidosis, hypoglycemia, although metformin doesn't cause hypoglycemia, but it does inhibit gluconeogenesis. And you know that our patients sometimes are starved for many days. Therefore, we need to make sure that we're not causing hypoglycemia by that mechanism. And the most frequent adverse event is gastrointestinal intolerance. And it is frequent. There's a lot of diarrhea, nausea, etc. So we're using the win ratio to analyze this, and the reason why we did it is because, of course, we're looking at a composite outcome, but we wanted to make sure that the composite outcome was not going to be only focusing on the GI discomfort, because there's other competing adverse effects that are perhaps are more important in terms of patient safety, like hyperlactatemia and metabolic acidosis. So win ratio allows you to rank those adverse events or the components of your composite outcome, and then use all that information to compute what the event rate is. The way it works is that at the end of the day, when you have all your data, you pair patients based on match-based risk, based on risk criteria that you assign, and then you look at those pairs and see who got an adverse effect. The first adverse effect, for example, hyperlactatemia. If the control did it, then that's a win for control. If the metformin group did it, then that's a win for the metformin group. If there's a tie, then there's a tie, and if there's none, there's none. If these two boxes are where those two patients are, then you go to the next level. And the next level is metabolic acidosis, and you do the same, and the same, and the same, until you get a proportion of wins to losses. And this is what we are gonna get out of this study to try to define safety. The secondary outcomes, we're going to do a very stringent pharmacokinetic analysis to look at elimination kinetics, because I told you that there's a risk of accumulation, and of course, a single dose PK profile to make sure that the drug is being absorbed in our patients, because again, remember that these are patients that are in shock. Key secondary outcomes are going to be, of course, feasibility. We've achieved this. We're enrolling about 2.75 patients per month. Adherence has been very good so far, but many patients are still in the trial, so I cannot give you more data so far. And the other thing is that we have very important key secondary outcomes that are going to talk about efficacy to inform future trials, like the kidney tubular stress measured by TIMP2 and IGVP7 that we're going to look at day 1, day 3, and day 5, and that area under the curve is going to tell us whether this is affecting tubular stress and injury. We're looking at platelet and peripheral blood mononuclear cell mitochondrial function live within an hour of collection, and severe acute kidney injury, of course. This is our hypothesis. Essentially, we submit that we are going to see differences in the adverse events, and it's probably going to be more secondary to GI discomfort. We think that this is going to be feasible, but we have to prove it. And then, of course, importantly, we think that this is going to protect the kidney from actually undergoing injurious metabolic reprogramming. So how is it going? This is where we are. We have enrolled 12 patients. We're on track. Last patient was enrolled on Friday when I landed in Brussels. I hope we can get another patient in when I land in Pittsburgh. And it's catching. There's already 4 studies in clinicaltrials.gov, 2 of which are enrolling. One of those is ours. The other 2 are not enrolling yet. So we'll see. We'll have more data on this soon. So in conclusion, kidney tubular AMPK activation is an adaptive mechanism. AMPK is susceptible to be treated exogenously with hopefully repurposing a medication that is cheap in our patients, and hopefully that is safe. The effect of metformin on sepsis-associated organ dysfunction and death has a true translational potential. And the other thing that we're trying to do with the trial is try to investigate which patients are going to respond best to metformin treatment to try to do what the previous speakers have said, which is phenotype a little bit better. With that, I want to thank funding agencies, all the people that have done the work, and join me in this, and I'll take some questions if there are any.
Thank you, Hernando, for a very nice talk and actually very interesting topic. I was trying to get my way around it. I'm still a bit confused on some parts. You know, we were told about metformin-induced acidosis, and there is still controversy. I also work in the operating room when we get patients from home on metformin, whether we should stop it or not. How do you balance this? And especially if this is successful, as we hope, how would you select those patients in which you can start it and which patient in which maybe is not the right moment to do it? Because often patients with sepsis, they come with acidosis, they come, there's the reason why they come to the ICU, and in a way you're hoping to prevent it.
Yeah, that could be complicated, but I think what this trial hopefully will do, and perhaps a multi-center if there's a signal, is that it will provide the guardrails along which you need to use this medication, right? I mean, if a patient is acidotic with a pH of 7.1 and that's all metabolic, you can't start it, period. It's like if you're going to use heparin and your PTT is 100, you can't use it. It's just not the right moment to do it. So I hope that that's going to be the case. I think it will give us a little bit of information about whether we should really stop metformin right from the get-go for the reasons that we consider today, or we shouldn't, regardless of whether or not that's going to help the kidney or not, or the organs. And second, hopefully it'll provide information as to whether we should really initiate it in people that are not on metformin. And the other important thing that I'll just say is that we are enrolling patients that are not diabetic. There's going to be a lot of patients that have nothing to do with metformin that could potentially benefit from it as well.
And with just a clarification, you showed us the observational parts in where you were showing that exposure to metformin was associated with better outcomes, but that was presumably chronic exposure to metformin in the community. And now you're thinking about an acute exposure, right, which is a little bit different. Am I right?
That is correct. That is correct. And again, this is the reason why we're doing the trial. That is chronic exposure. You're very, very well. Now, if you look at the pharmacokinetic properties of metformin, by day 3, you should have stable, steady state concentration. So despite the fact that that's chronic tonic exposure, there might be a hit. But I guess the trial will have to answer. This is uncharted territory. This has not been done.
Yeah, so in line. Oh, we've got a question. Yes, great. Microphone, please. Waiting for the microphone. One question. Do you have any concerns about the absorption? Because if a patient is septic shock, we have those patients on paralysis. I'm not aware of an IV metformin. So do you already have some experience with that?
Well, no, but we hope that we'll acquire it. That's why we're doing the pharmacokinetic study. And I'm telling you, this is the last time I will do a pharmacokinetic study. Last time in my life.
Okay, question here.
Yeah, yes, please. Thank you.
Oh. Yeah.
So I have 2 short questions. First, do you plan to adapt the dose in case of renal failure? I mean, diabetologists would decrease the dose in case of GFR below 30. Would you consider doing the same in a large confirmatory trial? And the second point is, which is your glycemic target? And what about the dose of insulin that, of course, will differ between the groups and could confound the results?
Thank you for those 2 very good questions. So for the first, right now, we are not enrolling patients with eGFR less than 30 because of the reasons that you mentioned. The only reason why we're decreasing the dose to half of what the dose would be is if we find persistent GI discomfort that is making it difficult for the patient to actually obtain, for example, nutrition and so on and so forth. So we have a protocol within that is going to de-escalate the dose of metformin or placebo by that means. And then the second question was, sorry.
Glycemic target and insulin.
Yes, thank you. So we are not focusing on a glycemic target. What we are doing is just making sure that the patients are not hypoglycemic. Again, by virtue of randomization, we're hopeful that the insulin levels that patients are getting are going to be balanced across the studies, but it's definitely something that we will need to look at. Again, I cannot target in glucose levels right now because it's blinded. So I just can't do it at this point.
Okay, thank you very much, Hernando. We're looking forward to the results of the trial. We go to the next speaker, Djillali Annane. Djillali Annane from Paris. Copper, maybe that's the new target.
Dear chairpersons, good afternoon. Dear colleagues, good afternoon. So here are my disclosures. I'm going to summarize in 10 minutes 5 years' works and more than hundreds of experiments. Most of the credit has to go to Rafael Rodriguez, who is a world-renowned chemist at the Curie Institute in Paris, working so far on cancer, and after having some wine together 5 years ago, he had some interest in looking at sepsis, and this is what we did together and led us to discover a new way of regulation of inflammation that might be relevant for both cancer and sepsis. So what we did, first, so we took monocytes from healthy donors. We stimulated with GM-CSF to obtain non-activated monocyte-derived macrophages. Then we stimulate them with LPS to get activated macrophages. So one can see here that activated macrophages have a high expression of CD44. Then we looked at copper, and one can see that there is a copper uptake or increase by activated macrophages. And we then use silent RNA to silence CD44 expression, and one can see that there is no more uptake of copper there. Likewise, when we use a monoclonal antibody against CD44, no more uptake of copper. So illustrating that the uptake of copper by activated macrophage is related to CD44. Then, as we know that hyaluronate has a major role in the regulation of expression of CD44 and the function of CD44, we also found that hyaluronate was important for the uptake of copper by the activated macrophages. And so one can see here the increase, and also we use a fluorescence probe of copper to demonstrate here that there is a co-location of hyaluronate and copper, highlighting that hyaluronate is important for copper uptake through CD44 expression at the surface of activated macrophages. And the subsequent experiments here highlighted that the uptake of copper is not regulated by copper transporter, so it's not mediated by copper transporter, it's really mediated by hyaluronate. And here again, using spectral analysis, we highlighted the strong interaction between hyaluronate and copper. So that was first part of the experiment, demonstrating that copper is uptaken by activated macrophages through CD44 expression and hyaluronate. So then we know that metformin actually is a chelator of copper. So we looked whether metformin could help downregulating the activation of the macrophages by chelating copper. Unfortunately, metformin had really mild effects and was not really able to antagonize the activation of the macrophages. So Raphael and his team in the Curie Institute worked on a new molecule that is a lipophilic copper camp 12 LCC12, now called subformin. And one can see here that subformin completely block the activation of the macrophages. And this is definitely mediated by chelating copper, as shown here in this spectral molecular analysis of LCC and copper complex, as well here on MNR spectra. So thereafter, we, for a drug to be active, the drug has to enter the cells. So we had to demonstrate that the drug indeed entered the cells. And this was the case. So here using again a probe, fluorescent probe indicate we using cytochrome C labeled with gold. We marked or labeled the mitochondria. And so one can see here that there is the drug is locating inside the cells and inside the mitochondria. So the drug is taken by the cells and enter the mitochondria. And again, here is illustrated that there is a co-location of copper and the drug in the mitochondria. And on the last panel here, what is shown is it's very important to know that copper is a major cofactor of the shuttle NADH to NAD, so which plays a major role in cell plasticity and the epigenetic phenomenon. Though one can see here that copper actually strongly activate that shuttle toward transforming NADH to NAD. And metformin here has no effect on that. And one can see here in the pink curve that the LCC2 completely blocked by chelating copper the shift from NADH to NAD, meaning that LCC2, by regulating copper in the mitochondria, will influence the epigenetic phenomenon and cell plasticity. And indeed, what happened is, because of that epigenetic phenomenon, this is the cells, the non-activated macrophages, the activated macrophages, and one can see that the LCC12 actually is not getting the cells back to the normal, to the non-activated phenotype, but to a different phenotype. And when looking at the difference in genes expression, in particular in the activated macrophages, so this is very well known. You can see here a number of genes that are upregulated when the macrophage is activated. And here one can see that LCC12 of subformin almost completely reverse and prevent this upregulation of these inflammatory mediators. When looking at the downregulated, at the genes that are downregulated by LCC12, there are roughly 3 clusters. One is related to cells migration, interleukin-1 pathway. The other one is related to the NADH-NAD metabolism and cycle. And the third one is related to chromatin generation and chromatin regulation. So how does that translate into, let's say, it's difficult to talk about clinical in animals, but still living people. So to live in vivo evaluation of the drug, I'm just showing here one example of the many models we did use. They all showed the exactly the same findings. So these mice were challenged with LPS, others were challenged by CLP, others by SARS-CoV-2, others by fungi, and there is a consistent effect of LCC12 or subformin. So this is in the model, the survival curve in the control group. So one can see that the LCC12 in that model almost completely reversed the mortality. This is the effect of dexamethasone. So, and there is this beneficial effect that was reproduced again in a number of sepsis models in small animals. We now have turned to investigate subformin in non-human primates. So we have started the experiments. For those who are interested to look at the whole story, it has been recently published in Nature. So because we are in a session of the future for the treatment of sepsis, so my guess is, of course, that this will by large rely on endotyping the patients. We will need digital twin at the bedside to integrate all the information and to modelize. And among the new treatments that are very likely to contribute reducing the burden of sepsis, there are subformin, small molecules, nanomolecules. So my guess is now we almost all are treating our patients alike, all of them using the same guidelines. In a decade or so, we will be definitely in an era of individualization of treatment based on fast delivery of endotypes at treatable traits at bedside, and innovative molecules, just like subformin, for example, that will be delivered to the patients according to information that will be get on real time in real life. Thank you very much for your attention.
Thank you for the great overview and insights. Are there any questions from the floor? Yes, there. Maybe get a microphone.
What's the effect?
Wait a second.
Yeah, here it is.
Thank you.
What's the effect of this drug on bacteria? Because there is an action on eukaryotic cells, but what is its action on bacteria?
So I don't have investigated this by myself, but copper at different dosage has been used in the past in the lab to kill bacteria, for example. But now using copper at this dosage in human would be toxic, very likely. Here, the issue, what we demonstrated is that one of the many mechanisms of regulation of inflammation is related to copper, mitochondrial copper, mediating epigenetic phenomenon.
Another question here.
Professor Annane, thank you for that very, very exciting talk. I have a question. You showed that subformin, it doesn't quite decrease the concentration of NADH, but when you looked at the metabolomics that you did, it seems like it decreases the functions of NADH, which leads me to think that perhaps there's some inhibition of complex 1 in the mitochondria, as metformin does. Have you looked into that, and what are the repercussions of subformin into cell metabolism, essentially?
Well, so again, we did all these, and we eliminated serially all potential mechanism. And actually, I refer you to the paper in Nature where you could find all the details. Actually, there is a strong decrease in NAD. So by chelating copper, really there is a strong decrease, downregulation of the shuttle NADH to NAD. So it's not only the function that is decreased, but also the quantity of NAD that is produced, that is reduced.
Thank you.
So, and one question from my side. So you now studied in LPS-induced animal models. You go to primates. Are you also going to do bacterial-induced sepsis in the primates or in the smaller animals? Because we know with LPS there might be a heterogeneity or no effect. So what's your take on that?
Oh yes, we did it. We did it several times by several requests by different reviewers at Nature.
Okay.
So we use E. coli instilled in the lung. We use Klebsiella pneumoniae. We use Staph aureus. We use Candida, different types of Candida. We even use Trypanosoma. So we did a lot of different model of severe infection and also viral infection, as I mentioned, SARS-CoV-2 and flu. And there was consistent finding. And one reason is because this is acting very upstream at the, at the chromatin level and epigenetic phenomenon. So at the level of cell plasticity, rather than blocking one specific point of the cascade.
Thank you, Djillali. Just one last comment. On one of your last slides, you put the future where we will do endotypes and digital. I love this, is my same vision, but you put, I think, 2030. I mean, that's very optimistic. I would love to see that. Do you think it's realistic for 2030?
I think so. Yeah, I think so for two reasons. First, we already have tons of biomarkers that we are misusing, and with the aim of AI, we will likely improve the way we use them. Regarding digital twins, it's really now emerging in the field of medicine. Cancer, for example, they're using digital twins of tumors for chemotherapy. The cardiovascular fields are already using digital twins of the heart.
We had a round table on artificial intelligence. The technology is there. We also said we should just get on and do it.
Yeah, exactly. So everything is there. So we have to go to these people. They won't come to us. We have to go to these people and to work with them and to bring these tools in the ICU.
Thank you, Djillali. So, great pleasure to us to come on stage to Professor Rinaldo Bellomo from Australia in his little introductions, I think.
Thank you very much, Maurizio. And instead of talking about copper, we're going to talk about vitamin C and ascorbate. As you're all familiar, this has been a long saga now, with vitamin C being known to be low in patients with sepsis and the fact that human beings cannot generate it by themselves. The activity was really triggered by this paper in Chest by a group led by Paul Marek, which showed an implausible effect on survival in human beings with sepsis, and eventually led us in Australia to conduct the first sort of significant study, which was randomized and controlled, of vitamin C in sepsis, and demonstrate that there really was no effect that was beneficial with the administration of vitamin C. So we were in our lab, in the animal lab, where we do a lot of experiments with sheep, trying to find another way to try and address the issue of improving outcome in sepsis. And we thought that trying to attenuate the effect of radical oxygen species was a good strategy. And I'm sure you guys spend all your time worrying about 4-hydroxy-2,6,6 tetramethylpyridine 1-oxal, like we did. This is a very powerful antioxidant. It's been known for quite a period of time. And so we gave it into the sheep. The idea was to stop acute kidney injury during gram-negative bacteremia. And if you infuse this drug into the renal artery, which you can see up there, if it worked, doesn't really quite work, you can see at the top right that it completely supported and maintained the oxygenation in the medulla. And at the bottom right, that it abrogated acute kidney injury. So I started writing my Nobel Prize speech for having sorted out acute renal failure once and for all, except that it was pointed out that no one was going to give it into the arterial tree and into the renal artery. We had to demonstrate that we could give it intravenously. But when you do, it doesn't work. So clearly there's got to be some mechanism at lung level or circulatory level before it gets into the kidney that removes its activity. So we thought, what else could we do that might be super effective as an antioxidant? And we thought, why don't we just give a massive amount of vitamin C? And so we had the animal model, and this is the model that we have in sheep. They become very tachycardic, very febrile, very tachypneic, they're hypotensive, they require noradrenaline infusion, they develop acute kidney injury, they lie at the bottom of the cage, they look drowsy, they don't eat, they don't drink, they look very much like a septic human being. And then we gave the first sheep a massive amount of vitamin C. I'm talking about 3.5 grams per kilogram. So in a human being, this is around 250, 260 grams over 6 hours. And the animal just stood up and looked at everybody and started eating and drinking. And the lab guys called me up and they said, we've seen something we've never seen before. And then we decided we would embark upon a research program. And the first thing we looked at is whether human beings have been treated with high-dose vitamin C in the past. And so you go into a scoping review and you look at whether people have used Megadose vitamin C, and you can identify about a year and a half ago, 74 studies. Most of these have been given to oncology patients in the forlorn hope that cancer would be cured. There are case reports of up to 250 grams in these patients. And there appear to be no adverse events. And there are only a few cases which appear to be idiosyncratic of hemolysis in patients with G6PD deficiency. No reports of oxalate nephropathy. And overall, Megadose vitamin C or sodium ascorbate appears remarkably safe. So we decided to proceed to do a full amount of work experimentally in the sheep. And this is our model, as I described before. We give intravenous gram-negative bacteria for 23 hours with fluid bolus, and then we randomize the animals to either have placebo, which is the vehicle for vitamin C, or in this particular case, a bolus of 30 grams followed by a continuous infusion of 120 grams, and we follow up the animals without giving any antibiotics. And this is what happens. You can see in red the noradrenaline or norepinephrine levels going up as the animal becomes more and more septic and hypotensive and shocked. But as soon as you give sodium ascorbate, it all goes away. And you can see that the blood pressure is maintained at the same levels. And you can look at other outcomes, and you can see them there. And again, there are significant effects on body temperature. So the animal body temperature goes down by about 2 degrees compared to placebo. And of course, the heart rate gets better. And these animals are highly aggressively and intensively monitored. We put a whole sorts of probes into the kidney and now the brain, which are invasively inserted about 3 weeks before the experiment. And we were able to demonstrate that you have significant medullary hypoxemia if you have sepsis, but if you give sodium ascorbate and megadoses, you resolve it. Both perfusion by laser Doppler flowmetry and oxygenation can be corrected by sodium ascorbate. The urinary output increase is dramatic in this setting, and the plasma creatinine fall is equally dramatic compared to placebo. This is a representation of cerebral oxygenation and cerebral perfusion and cerebral temperature, again invasively measured, and you can see in orange the effect of sodium ascorbate, again beneficial with increased cerebral perfusion, cerebral oxygenation, and a decrease in cerebral temperature. So we try to understand a little bit what might be happening. Why is this happening? Are we having an effect on cytokines? This is just a sample, IL-6 and IL-10. There really wasn't much that was happening there. A little bit of an effect on MIP and the endothelial growth factor, but really nothing particularly dramatic. There was a much more dramatic effect on nitrite release, which was significantly attenuated with sodium ascorbate. So this might be a potential mechanism by which it works. And of course, we achieved stratospheric ascorbate levels. You can see at the bottom, it's basically not identifiable, not measurable in the sheep during septic shock. But if you give the megadose ascorbate, we have blood levels of almost 20 millimoles of ascorbate in blood. Of course, you've seen all these hemodynamic changes, and one of the things that we asked ourselves is whether this is the sodium. It's got nothing to do with ascorbate. You've got more urinary output, more blood pressure, and many of you would say, we've just given the patient, in this particular case, the sheep, a sodium load, and we compared sodium ascorbate with sodium bicarbonate with exactly the same amount of sodium content, the same amount of volume, and you can see that there is a clear difference, and it's not the sodium that has made the effects that we've seen in the sheep happen. And so in response to all this information, we proceeded to do a phase 1 study. This is in human beings with vasodilatory shock, and we were allowed by the ethics committee to give a maximum of 60 grams to these human beings. So 30 grams over 1 hour, followed by 30 grams over 5 hours versus placebo. This is a phase 1 randomized double-blind placebo-controlled trial with 30 patients randomized together. You can see the baseline characteristics of these patients, and they seem to be reasonably balanced. And this is what we saw in terms of urinary output. There was a significant difference between placebo and sodium ascorbate, with a greater urinary output with sodium ascorbate, and there was a significant decrease in the norepinephrine or noradrenaline infusion rate necessary to maintain target blood pressure. The serum sodium went up, as this is a somewhat hypertonic solution, and you can see that there was a significant difference between the two groups. The creatinine, however, did not change between the two groups. However, the patients that we randomized did not develop significant acute kidney injury with standard care, so we were unable to identify a difference. But there was a decrease in the SOFA score when comparing the two treatments as well. The levels of vitamin C that we achieved, or ascorbate that we achieved, are about a fourth of what we've seen in the sheep. So we're still underdosing at this stage in the pilot phase of our investigations. And then, of course, you've all seen the LAVI trial, which demonstrated a potential for harm with the administration of high-dose vitamin C, raising concern about what vitamin C may or may not do if we continue to pursue our investigations. However, it turns out that the product that we're using, which is pH-balanced sodium ascorbate, is actually profoundly different from the ascorbic acid that was used in the LAVI trial. We're fortunate enough to ask Sean Bagshaw from Canada to buy us the LAVI trial Mylan vitamin C ascorbic acid preparation, which he promptly put on a plane and sent it to us. And you can see the difference in arterial blood pH in the sheep if you're giving sodium ascorbate, which is pH balanced, has got a pH of around 7, versus the Mylan ascorbic acid preparation that was used in the LAVIT trial, which has a pH of about 4 to 5. So a clear acidification of plasma, which may well have contributed to the findings in the LAVIT trial. And this is yet another representation of changes. If you let the ascorbic acid sit and be exposed to light, you can see the difference between a pH unbalanced and a pH balanced preparation. So it appears that sodium ascorbate pH balance versus the Mylan ascorbic acid product might really represent two different interventions. And if you become obsessed with this kind of stuff, as inevitably all investigators do, and you go to the literature, you find that in 1978, there was a very nice paper showing that the administration of ascorbic acid in cats induces severe metabolic acidemia. So let me conclude by saying that high-dose vitamin C does not appear to have a clinically important beneficial effect in human sepsis as far as we understand it at this stage. However, we also know from the oncological studies that Megadose vitamin C is remarkably safe in humans. We now move to studying a pH balanced preparation of sodium ascorbate at megadoses in sheep. In our model of gram-negative bacteremia, the effect of this medication was dramatic with strong beneficial physiological effects. We've now completed a pilot phase 1 double-blind randomized controlled trial of an elevated dose, but not as high, of ascorbate at 60 grams, and we've replicated some of the features observed with much higher doses in sheep. And we're now continuing our investigations, and this year we're going to move on to a phase 1b study at higher doses to demonstrate safety and perhaps efficacy. Thank you very much.
Thank you, Rinaldo, for a great talk. Question, Michael Pinsky, microphone here in the front, please. He's coming.
Michael.
Thank you. First of all, congratulations. That's a beautiful study. I love your work. The fundamental question that I would like to ask is, what is the mechanism by which you expect to see this? Because if all you're doing is inhibiting nitrate and nitrite, we have other molecules that do that, and we already know that in large studies they don't work. So I'm very excited about what you're showing me, but I'm very concerned because I don't understand what the mechanism is that is causing it.
And I think that's really important, Michael. And neither, I think unless we got a better understanding of the mechanism, this isn't really going to kind of have a narrative in the end. So we're in the middle of just massive investigations in every direction, both looking at mitochondrial integrity, mitochondrial activity, electron flux across the mitochondria, spectroscopy, metabolomics. Like, we've got a big grant now, and we're investigating all possible mechanisms. At this moment, I don't have an explanation. It's striking clinically, but I don't have a mechanism, which is disappointing and problematic. Hopefully next year or the year after everything's come in, I will be able to give some kind of explanation. But I agree. I completely agree, yeah.
Rinaldo, can you comment, the data that you show in the lab is almost too good to be truth? It's very powerful, the separation of effects there. Yeah. Is it possible that is related to the tight control of the time zero of sepsis there, that maybe you don't have in a clinical situation, or you really think that...
Yeah, look, I think you're right. I think it's possible. We never replicate what's happening in human beings. And our model, it goes on for 24 hours before we intervene. So, it's pretty established. And so we got plenty of time to cause trouble and then try to respond to severe trouble. But, all the models are just models, and then, we now have 2 other models underway in mice and rats. We'll see what they show with sickle ligation puncture and lipopolysaccharide to see if they replicate what we see in the sheep. And I am fully aware that this is just a really limited reality that we're working with.
And if you look at the LOVIT trial, would you kind of repeat it just with a megadose of sodium ascorbate, or would you change something else in the design?
Look, I feel very uncomfortable with what's been done so far with vitamin C in light of our experiments, and I think we're going back to square one. What happened with vitamin C, there was an implausible paper published in Chest. Everybody went bananas, and then the whole thing just skyrocketed into trials without, as Michael said, any understanding of the putative mechanism, any background work in animals, any studies that were pilot and try to understand what might be happening. I want to go back and do the opposite with sodium ascorbate and megadose, just step by step by step, I don't know how long it's going to take me. Maybe I'm going to be dead before I get there, but the idea is that I want to do the opposite of what's been done with vitamin C.
And maybe just one last question, similar to what I was asking to Julie before. Are you also looking at potential biomarkers to think which patient will benefit from the megadose? And
not at this stage. Not at this stage. Yeah.
All right. Thank you very much. And we go to the next speaker, Arthur van Zanten, Ede, Netherlands. A comeback for glutamine.
Thank you very much, Alexander. Yes, maybe a comeback for glutamine. Let's see. Here you see my disclosures. So it's more a talk about confessions. Why do I reconsider my previous ideas on glutamine? Because I'm well known for not be very in favor of glutamine, but based on recent insight, I must admit that maybe I have to, well, readjust my previous position here. And glutamine, well, can be administered by the enteral route or intravenously and may have an impact on many organ systems and inflammatory processes. We give glutamine, we give glutamine because in the plasma we measure low glutamine levels in many patients, so it's a non-essential amino acid, so it could be made through other amino acids, but maybe it's conditionally deficient. So due to the severity of illness, it may be that the production of glutamine is limited, and there are some intracellular processes or studies done that have suggested this hypothesis. However, what we measure in plasma is maybe not what's happening in the muscles, because there is a highly regulated pool of glutamine in muscles as well as in the liver. However, it's an important amino acids, the most abundant even in the human being, and it's also associated with the urea-ammonia pathways. So overdosing glutamine may induce more production also of urea. But it's also important for mitochondrial function, and it is a precursor of alpha-ketoglutarate, important for the citric acid cycle, as you know, important for the production of ATP. Now, what's the evidence? I think the most important large randomized controlled trial on glutamine has been performed by Darren Hyland and co-workers, published in the New England Journal of Medicine, giving a very high dose of glutamine to patients in a factorial design, also with other antioxidants. And the results of this study were that there was a strong trend, if not a significant effect on mortality, and increased mortality in those patients treated with glutamine. So then our enthusiasm for glutamine was, of course, below zero. And also in the subgroups, there was not a group that really benefited from glutamine administration. There was a subgroup of patients in this study with plasma levels, and what is known from other studies is that there's probably a U-shaped relationship. So very low glutamine levels are associated with increased mortality, but also very high. And in the subset of patients treated with glutamine, we can see, I think this doesn't work so well, that some of the patients went over this threshold of 930 associated with increased mortality. Moreover, patients with AKI showed a higher relative risk when treated with glutamine. So especially those patients with kidney injury, we saw the harm. And then we performed the MetaPlus study, a study with enteral products. So we changed the composition of an enteral feed. We enhanced the dose of glutamine, but also put fish oil into this enteral feed and antioxidant vitamins. And it's some time ago, but our idea was that we could reduce nosocomial infections by this new feed. But to our surprise or disappointment, we didn't find any effect on the primary endpoint infections. However, in the secondary endpoint, especially in the medical group with the sepsis patients and the ARDS patients, we found increased mortality. Here you see the different Kaplan-Meier survival curves, a clear signal of harm in this specific medical group. And after Cox proportional regression analysis, we can see that there was even a 57% increased risk of being randomized to this new feed. And then Darren Highland and me, we talked about it, and we found similar effects of glutamine. So we were very convinced that glutamine was maybe dangerous for the patient, and in a post-hoc analysis, we found also that those patients with a higher baseline glutamine level showed, a less favorable effect of the glutamine administration. So we sent out warnings that given that our first dictum in medicine is not to do harm, that we should reconsider the use of glutamine based on these two studies. Now what happened afterwards, we did a post-hoc analysis, and it's difficult to do this when you have more ingredients in the intervention arm than just a single one. But we tried to do this kind of moderator-mediator analysis, and we found actually that there was not really a signal for glutamine, but there was a signal for increase of the fish oil components in the plasma. And when we did the multivariable analysis, we found that in the first 4 days, in those patients with a large increase of the fish oil levels in the blood, there was an association with increased mortality, and this was not found for glutamine. So we ended up with this kind of models, and it was suggested by statistical methods that probably the fish oil did the harm and not the glutamine. So that's one aspect of our MetaPlus study. Then we did a meta-analysis on the enteral glutamine supplementation. There was not so much effect of enteral glutamine, maybe a reduction in hospital lengths of stay, not in trauma patients, and possibly in burn patients, but you must have heard about the large trial of glutamine in burns patients, and there was not really an effect. But there was also not an effect of enteral glutamine on hospital mortality. But maybe it could be different for IV glutamine supplementation. Why in parenteral nutrition there is no glutamine in the standard products? Because it induces stability and compatibility issues. So if you want to give glutamine, you have to add this at the last moment, as for instance alanine glutamine dipeptide. That's another way of doing this. Now, after this study, a meta-analysis was performed by this group of investigators studying the effect of glutamine in parenteral nutrition, but only selecting those studies where the glutamine was given in the reasonable dosages recommended by the manufacturer. So not the very high doses used by Darren Highland. And what they found were better results. So a reduction of length of stay in the ICU and the hospital, and also a significant reduction in mortality. Why could this be? And there is new information that shed lights on the redox trial. And that's UCR, urea creatinine ratio. So when we give the proteins to a patient and they cannot be used for muscle protein synthesis or acute phase protein synthesis, they will be in the end via the pathways I've showed you, via ammonia and urea, be discarded and not used. So an elevation of the plasma urea levels could be a reflection of proteins not be metabolized or used by muscle cells, for instance. So they're not useful. And in this post-hoc analysis of the redox trial, they found that those patients with a high UCR, urea to creatinine ratio to reflect the kidney function and the muscle mass, was associated with worse outcomes. And they also did some kind of moderator-mediator analysis, and then they found that the mortality risk was driven via the interaction with the urea-creatinine ratio. In other words, maybe it's not the glutamine itself, but it could be the protein dose given to patients that couldn't handle the protein dose from a metabolic perspective. And why could this be? Well, we heard about mitochondrial dysfunction. The moment there is lack of ATP in the cells, there will be signaling to the nucleus of the cell to reduce the protein production, so the protein transcription. So in other way, ATP deficiency in cells is a condition of proteostasis, so there will be a lack of protein production. So what happens when we give a lot of proteins to a patient in this metabolic condition? There will be a lot of urea production. And it's striking also to see that there was an interaction with patients with AKI that could not handle maybe the effects of proteins that cannot be used in protein synthesis. Moreover, recently this study was performed by one of my postdocs with Imre Kouw with Leanne Chapel in Australia using whole protein. So they fed a cow with stable isotope that will produce milk proteins you can give to ICU patients, and then you can measure the digestion and absorption of the proteins, because they have to be split in dipeptides and amino acids to be able to be absorbed in the gut, and they will be present in abundance in the plasma. And what they found on day 4 of ICU stay, that the absorption and digestion of these whole proteins was absolutely comparable with healthy persons. So there is not malabsorption in ICU patients. However, on a cellular level of the skeletal muscles, they found there was a less production of muscle proteins. So there is anabolic resistance. So you can give a lot of substrate, but it is not used. Another explanation could be that we dose our proteins or glutamine now on total body weight. And this is a study we did during the COVID time. These are 150 patients. And what you can see that if you look at the lean body mass, so that's everything without fat, so that's bone, muscles and organs, and muscles is the majority of the lean body mass, you can see that there is a huge difference between males and females. As you're probably all aware, that males have more muscles, but still, while dosing nutrition, we take the same equations, 1.3 gram per kg of total body weight. And you can also see, I've selected 2 males here and here, of a body weight of 100 kilogram, and the lean mass can be a difference of 30 kilogram. So that's relevant. So we do a lot of bioelectrical impedance assessment, so we dissect the body in the body composition, and we know the fat-free mass. There are some complications because you have to adjust for extracellular water, for edema. But typically we give normally 100 kilo times 1.3 grams is 130 grams of proteins. But when we take these 2 males, the protein dose based on the adjusted fat-free mass for this patient should be 100 gram, and for this one 152 gram, meaning that this patient received 13 grams of protein overdosing, and this one 22 grams of protein underdosing. So I think we have to individualize the protein dose maybe to the lean body mass. And in the EFFORT trial, a large recent study with very high protein targets, up to 2.2 grams per kg per day, and they realized slightly lower, 1.6, and the usual dose was 1.2, and they realized 0.9 grams, so a clear separation of protein dose. There was not an effect on the primary endpoint, the time to discharge alive from the hospital by treatment group at day 60. However, they found in the groups with AKI and high SOFA scores, there was harm by the high protein intervention. And also in this study, they did post-hoc analysis of the UCR, the urea to creatinine ratio, and there was a strong signal that the harm was induced, especially in those patients with high urea to creatinine levels. So we have to individualize our strategy and, if you wish, listen to the metabolism of the patient. And this is a reflection of this from a single patient in our ICU. This is a patient in the ICU for 75 days. You see a gradual decrease of the serum creatinine levels, reflecting the loss of muscle mass over time in the ICU. This patient didn't have renal failure, and the protein intake on a daily basis was exactly the same the whole time. But every time there was an infectious complication, an increase in CRP, you see that afterwards, for 10 to 14 days, there is an increase in UCR, suggesting that the proteins we give cannot be handled by the individual patient, the metabolism. So we have to reconsider whether we should give high protein doses to patients that cannot handle this from a metabolic perspective. And that's maybe also the problem for the glutamine supplementation. So we typically in nutrition do one size fits all, one equation for energy and protein for the whole ICU stay. So the next step is that we go for body composition and give the proteins 1.85 grams per FFM kilogram, so for the fat-free mass. But the next step is maybe more endotyping, that we use biomarkers, maybe UCR or other biomarkers, to know whether the proteins we give, of the energy, the kcals we give to the patients, are really handled well by the metabolism of the patient. So it's becoming not more simple, but maybe there's an explanation why we found negative effects in the glutamine trials, and maybe we should reconsider the use of glutamine. So I want to conclude, enteroglutamine supplementation maybe is less important because normal enteral nutrition already contains about 6 grams of glutamine per liter. But in parenteral nutrition, especially when you give total parenteral nutrition, you may consider to use a balanced amino acid solution, so adding glutamine, but not in very high dosages, so keep it low, and do not go over the recommended dosages. Or you have to have the possibility to measure plasma glutamine levels, but that's not available in many centers. So, and I think for the future, we have to individualize protein dosing based on maybe the muscle mass or the fat-free mass and not on the total body weight. And maybe we can use the urea-creatinine ratio as a biomarker to see whether the proteins we give to the patient are metabolically handled optimally, and or whether we should reduce the protein intake because the urea production is too high. With that, I'd like to conclude and thank you for your attention.
Well, thank you very much. The floor is open for questions. And in the meanwhile, the measurement you were mentioning already, glutamine, it's not available in all centers, but what's the turnaround time of a normal test if you would have it in your center?
For glutamine?
Yeah.
Well, if we send it to a lab, it will take a week or so. It's too much to, if you want to have it, then you need it on the same day, because then you can adjust your protein intake. So I think it's not the way to go forward. We don't know whether we can monitor glutamine administration with UCR, but we can test that in the future. But in general, I think when we would have done the redox trial, maybe with arginine or with another amino acid in a very high dose, we could have seen maybe the same effects, because that's what we see now in the effort trial. Also, when you overdose proteins, especially in the early phase of critical illness, I think metabolism cannot handle that, and you run into complications, especially in those patients that cannot handle the proteins. And it's also interesting to see, when you see the patients with renal failure on renal replacement therapy, that the effect is less, for two reasons. One is you remove the urea and side effects of high protein dosing in renal failure. And secondly, you remove some of the proteins, because you lose some of the proteins into the ultrafiltrate. So I think we have to reconsider the concept, and maybe in a later phase, a higher protein dose is better for our patients.
Yeah. Question there, please, the microphone. Waiting for the microphone. I think indeed we need this direct feedback. So I like the urea-creatinine ratio, because the whole endotyping, phenotyping, then we need to have some direct feedback. So good to have that.
Yeah, thank you, Arthur. Excellent. Do you think, or can you, so the question I have simply is, would you now start a trial with glutamine supplementation in parenteral nutrition in septic patients? And to extrapolate on that, would you look, we heard today about hyperinflammatory phenotypes and low inflammatory phenotype. Would you add more into inclusion-exclusion criteria if we would ever do another glutamine in sepsis trial?
Yes, that's a great question. Actually, we do some studies now to do also metabolomics and try to find out the immunometabolic consequences, because there is a strong interaction between inflammation and metabolism. And I think that's a new field we have to address more in the future. And yes, you're right. I think we need some better phenotyping of the patients to know which patients we have to give this intervention. We've seen such great presentations during this meeting. Also, we can have the same outcomes, but when we know which patients to supplement and not based on more metabolic or immunological co-variables, we're better able to see a difference. So I would not go for a standard glutamine study in sepsis, but we have to do some kind of enrichment of our population. But still, I think understanding metabolism is very complex, as is inflammation, and now we also have the interaction between the two themes here. So I think maybe we are, like Rinaldo said, maybe we have to do more basic work before we start to do these studies again.
Thank you very much, Arthur.
Thank you.
So I want to ask Professor Peter Pickers to join us on stage for the next talk.
Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. Last phase of the afternoon. This talk is about alkaline phosphatase for kidney protection in patients with sepsis. And we all know alkaline phosphatase because we use that frequently as a measure of liver dysfunction. But we have to realize that this is an enzyme that is a detoxifying enzyme. And it does so by removing phosphate from different compounds. Now, interestingly, endotoxin itself, that might be relevant during sepsis, also has two phosphate groups. And when it binds to its receptor, a whole inflammatory cascade is initiated, and then you die. So if you actually would have alkaline phosphatase present and remove one phosphate group of endotoxin, it can still bind to its toll-like receptor 4, but the whole cascade will not happen anymore. And even more so, it will act as an antagonist for endotoxin with two phosphate groups. And it's not only endotoxin, there are multiple compounds that have phosphate groups that make them toxic. And if you remove the phosphate, then they are not toxic anymore. So therefore, it was thought that it might be that this alkaline phosphatase had therapeutic efficacy in patients with sepsis. Now, in the meantime, since 2006 or so, 4 trials have been performed in humans, in patients, and I will go through these trials and not go over the animal data that shows similar effects. The very first one was using a bovine alkaline phosphatase made from the intestinals of cows. And this was a small phase 2 trial in sepsis patients, only 36 patients. So all-comers sepsis. What we found, on the left, I will every time depict the renal effects, and on the right, the mortality effect if the groups are sufficiently large. What we found was in the patients that received the alkaline phosphatase, the urinary excretion of tubular injury markers was less pronounced. And also the plasma creatinine turned out to go down instead of going up a bit in the patients in the placebo group. So indeed, creatinine clearance improved in the patients that received alkaline phosphatase. And of course, mortality effects were not relevant. Oh, in addition, as you can see on the right here, those patients that had AKI at baseline had less time on renal replacement therapy, and those that did not have AKI at baseline had a lower incidence to actually develop AKI during the course of the sepsis. So based on this, a second small study was performed, again with the bovine alkaline phosphatase, and this was called the ARDS trial, again a very small phase 2 trial in 36 patients only, but now focusing on sepsis patients with early AKI. And the primary endpoint was a composite of endogenous creatinine clearance and on the incidence and duration of renal replacement therapy. And again, as you can see here, in the patients that received alkaline phosphatase, the improvement of the endogenous creatinine clearance was more pronounced, And also they needed less time, there was a lower incidence and less time on renal replacement therapy if that was needed. This was a statistically significant effect in 36 patients only. So we became more and more enthusiastic about this kidney protective effects of this alkaline phosphatase. So based on these 2 small trials with the bovine product, it was decided by the company to actually develop a human recombinant alkaline phosphatase. And they did so very cleverly, combining placental alkaline phosphatase domain and the intestinal domain. The placental one has a very long half-life, the intestinal one has the highest biological activity. So we have a very high activity, long half-life compound as a consequence. So this time with the recombinant alkaline phosphatase, the phase 2 trial was done in 300 patients, again with sepsis and early AKI. And the primary endpoint was the effect again on endogenous creatinine clearance in the first 7 days. We chose the first 7 days because we thought that we want to look at an acute effect and also that we would have less missing patients because some of them might die and the other ones might be so good that they would leave the ICU, making the measurements more difficult. What we found was this. Over the first 7 days, indeed, the endogenous creatinine clearance tended to be more improved in the treatment group. However, this was far from being statistically significant, so the primary endpoint was not met. However, we followed up also the endogenous creatinine clearance over 28 days, and over the total duration, this was a significant improvement by the treatment compared to placebo. As a secondary endpoint, we looked at mortality, and much to our surprise, we found a huge effect on mortality. These were patients with septic shock on a vasopressor, 90% of them, 70% on mechanical ventilation, and all had AKI. So it's not like the placebo group was like a very bad outcome because they had a mortality that you would expect or even maybe lower, but we had a very low mortality in the patients that were treated with alkaline phosphatase, half almost compared to the placebo. And this was statistically significant in 300 patients and again also for day 90 mortality. As a consequence, the major adverse kidney events were also significantly improved in the patients that were treated with the recombinant alkaline phosphatase. So based on this, the phase 3 trial was designed. Again, we used the human recombinant alkaline phosphatase. The name of the study was Revival, and we had 3 cohorts, a main cohort, a cohort with patients with chronic kidney disease, and also a separate cohort with patients with COVID-19 that also suffered from AKI. We planned 4 interim analyses and we had predefined stopping rules for futility or early success. And because the signal was there for mortality, the decision was made that primary endpoint would be mortality at day 28. And we left alone the renal endpoints that we have been interested in up to this time. This was a worldwide trial, 120 sites in 15 countries, and we discussed with the authorities and they agreed about this design. So Europe, North America, but also Australia, New Zealand and Japan participated in this trial. So the short version of the in and exclusion criteria are that we had informed consent, adult patients, we wanted patients on sepsis and a vasopressor, so they had to be septic, it's not septic shock anymore. We did not look at lactate, but we found in the previous trial that patients that were not on a vasopressor had a very low event rate of mortality, so that's why we wanted that. And we used the KDIGO criteria for AKI. We had the usual exclusion criteria, and there were a couple of differences between the previous trial. So one thing, what I just said, the patients on vasopressor, because otherwise the event rate of mortality would be too low. We would exclude mild sepsis-associated AKI patients, so meaning you could fulfill the AKI definition, but we would measure the endogenous creatinine clearance. If it was above 60 mils per minute, it's too mild. These patients did not have a benefit in the earlier trial either. And we changed the primary endpoint, very importantly, as you will see. This is the flow chart of the trial. And as you can see, we randomized about 650 patients, and then the trial was stopped. I will tell you why, because the primary endpoint mortality showed the stopping rule for futility. There was no effect on mortality whatsoever. Nevertheless, with the patients enrolled, the key secondary outcome was again major adverse kidney events. And this was improved by the drug again, and also with statistical significance. And if we break down the MAKE 90, we could see that it was mainly driven by the number of patients that needed renal replacement therapy. As a post hoc analysis, we looked at pre-existent renal function to see if there was a relationship with the therapeutic efficacy of the drug. And what we found was that if your pre-existent, so prior to the ICU admission with sepsis and AKI, if your pre-existent renal function was worse, that there was actually a much higher risk of having a MAKE event in the patients that received placebo. This is what you would expect. You have less renal reserve. However, this relationship was completely gone in the patients that received ilofatase alpha, the recombinant alkaline phosphatase. So that means that the renal therapeutic efficacy of the drug is more pronounced in patients with a lower pre-AKI GFR. The overall summary of the adverse event is boring. There are no specific adverse events that emerged at all. No specific. So actually, as you can see by the p-value, less adverse events were reported in the active group compared to placebo in this double-blinded trial. So, to put this in summary, these 4 trials, is that we found renal protective effects in animal studies, in patients. If we measured tubular injury biomarkers, we found it. If we measured up to 28-day endogenous creatinine clearance, we found it. And we found it on MAKE 90 events. In STOP AKI, the first 300-patient trial, phase 2 trial with the recombinant, we found a survival benefit. We could not confirm that in revival. So this is the conclusion so far. So just published a couple of weeks ago is an additional analysis that we did using machine learning and using the baseline demographic characteristics of the patients to see if we can actually decipher if there's a phenotype that benefits more of the therapeutic efficacy of this drug. I will not go into the details of the analysis, but indeed what we found is a phenotype 1 and a phenotype 2, and those with the phenotype 1 have a lower lactate, lower disease severity score, and higher hematocrit and a higher bicarbonate, and these are the ones that are less likely to actually experience a major adverse kidney event. And the phenotype 2 is the opposite in every way, and these people are more likely to have a MAKE 90. And if we then look at the therapeutic efficacy, then the ones that are less likely to have it show no benefit at all of the ilofatase alpha treatment, while the ones that are more likely to have the phenotype that is more likely to have a MAKE 90 event indeed shows a significant benefit of the treatment. And in this subgroup of patients, the number of people, the absolute percentage reduction in MAKE is 14%, while it was 8% in the total group. So there's a more pronounced therapeutic effect. So to conclude, it's difficult to choose the right endpoint at the right time. When we choose 7 days endogenous creatinine clearance, it was later clearance. It was a renal endpoint, and we found a mortality benefit that was significant. Then, when the decision was made to make mortality the primary endpoint, we did not find that, but we still found the MAKE 90 renal effect that was significant. So we found no consistent survival benefit. We did see a consistent benefit for the kidneys. And everybody that you discuss this with is clear that the renal effects of ilofatase alpha are also of clinical relevance. If you have 8 to 14% less people that need renal replacement therapy or have a MAKE 90 event, this is also of relevance. So to find out indeed if we can reproduce it, we should need a new trial, and that might focus on patients with pre-existent impaired renal function to enrich that patient group. And I want to end mainly that we have a couple of negative trials with really consistent renal benefit. So personally for me, it's really frustrating actually that it's depending on a human choice what the primary endpoint is, and that might actually have a drug that is failed and is killed by that, or you might have a drug that would have to be registered and we would treat these patients. To be continued, I hope, and I thank the trial steering committee, all people on the right, and you for your attention. Thank you very much.
Thank you, Peter. We have time for one or two questions. While the microphone is, I don't want to rub my finger, but you had very strong signals on the renal outcomes. And maybe you already have that evidence that you're looking for now on a larger trials. What was the rationale from the study group to go to mortality? Because, you know, an improvement in renal outcome is already so important that a secondary outcome in mortality, if it comes up, we would have, you know, welcomed it.
Yeah, so I think most people in the steering committee actually were against mortality because if you work in the ICU research world, everybody's afraid for mortality. But it's also a commercial decision. So the company has to raise money, get investors, etc. And then it's so much easier if you would have mortality and have this signal that's really strong and say, look, we have this, we want money to confirm this. And so this is also, so it's not only research, it's also other influences that are there. And then
Thank you.
Like this happen.
Michael Pinsky.
Thank you very much. First of all, Peter, congratulations. My basic science clinical hat has to come on now and ask you a couple of specific questions. Number one, when you were giving this alkaline phosphatase and you presumed it was blocking the activation of the white blood cells, did you take white blood cells from human beings with sepsis and see that their CD11b, CD18 expression was appropriately decreased and was proportional to the increase in serum alkaline phosphatase? Okay, that's the first question.
Yes, that has not been done in these clinical trials. It has been done in vitro and preclinical work, and there it's found indeed that there is a relationship. The higher the alkaline phosphatase, the more immune suppression actually. We did try it in the very first trial and measure such systemic cytokines, for example, but there we did not succeed to find a big signal that there was a lower cytokine concentration, for example, in these patients.
One more brief question and then brief answer, please.
Okay. By the way, because that's an important thing, is we're talking mechanism of disease. And the second one is, did you ever look at the stratification of acute kidney injury markers in the patients that were given, like the nephrocheck, for example?
Yes, we did that as well in the previous trial. And also there was actually no difference, and the thinking was actually that we selected patients that already had AKI. So the kinetics of the markers was actually a couple of days before, and we missed that signal. So we looked at that in the Stop AKI trial, and we missed there was no difference between the treatment groups. Excellent.
Great. Looking forward to be continued.
All right.
All right. So we welcome back to the stage Djillali Annane with new therapeutic perspective in sepsis, nanocorticosteroids.
Thank you again. So now we will talk about corticosteroids. This morning my conflict of interest and again colleagues and friends to whom all the credit should go. So this morning we talk about trying to figure out which patient will best benefit from corticosteroids by discussing autotyping and so on. Another way of precision medicine is to try to figure out how can we better deliver corticosteroids to target specific organs or specific cells. So one way to do this precision medicine is to use nanomolecules. So we built some nanodexamethasone, actually, as summarized on these slides. We use dexamethasone palmipad for that purpose to allow having a very well-designed nano-dexamethasone, as you can see here. So here one can see the plasma concentration of dexamethasone when using nanodex, so nanodex is here, so almost no concentration that could be detected in the plasma compared to free dexamethasone. And here in electron microscopy, you can note within the nanoparticle the molecule of dexamethasone. So again, the concentration of the drug versus free dexamethasone in the lung and in the blood. So once again, the lung here, the blood here, and you have the nanodex and free dex. So in the lung, of course, as we're delivering the nanodexamethasone by nebulization, one can see that we can get much higher concentration of dex than when dex giving as free dexamethasone intravenously. And in the blood, there was much less concentration of dex when delivered by the nanodex as compared to free dexamethasone. Well, not going to detail all these experiments, but basically we wanted to understand which cell is actually taken dexamethasone when provided and delivered as nanodexamethasone. So basically we looked at macrophages, of course, and also neutrophils and endothelial cells that I'm not showing there, but one can see that we looked at different types of macrophages, macrophages in the alveolar versus macrophages in the interstitium. And very clearly, it's alveolar macrophages that are taking almost all dexamethasone when given as a nano-dexamethasone, and a little of it went to the interstitial macrophages. And the uptake is very fast of dexamethasone by these cells. So it's very important to understand that when you give corticosteroids, inhaled corticosteroids, most of the molecule stay in the bronchi, do not go up to the alveolar. And this is why the previous attempt of treating acute respiratory failure or ARDS by inhaled corticosteroids might have failed. So it's very important that in lung inflammation, we are able to deliver dexamethasone in the lung, in the alveolar. So we had to develop a specific device for small animals to allow that nebulization of the drug to permit the distribution toward deep lung. And also, not time to show it here, but also as compared to free dexamethasone, the nanoparticle, the nanodex, almost never deposit on the bronchi, and almost all the molecule go up to the alveolar. And this may explain the big difference I showed in previous slides in lung concentration of dexamethasone when given as a nanoparticle. So here you can see what are the general effects on the animals of giving that nanodexamethasone. After being challenged by LPS, for example, there is improvement in temperature and body weight, reductions in lethargy, bronchial secretions, and reactivity to different stimuli. At the cell level, using flow cytometry, again, we showed that nanodexamethasone actually is indeed reversing our downregulating activation of macrophages, of the alveolar macrophages, and reducing, for example, the release of tumor necrosis alpha. With regard to the function of cells, so we looked at the functions of neutrophils as well as of alveolar macrophages, and in both cells, we found that nanodexamethasone downregulated at a greater level than free dexamethasone any LPS-triggered alteration in the cell's function. Comparing again alveolar macrophages and interstitium macrophages, there was substantial differences, and I remind you, as shown in the previous slides, that most of nanodexamethasone is captured by the alveolar macrophages, not by the interstitium. And so there is a downregulation of activation of the alveolar macrophages, not of the interstitium macrophages. So highlighting that we are able to really do precise medicine and target different type of cells to regulate the function of these different cells. And this translated in improvement in survival, of course, in the animals. One thing that is interesting here is in this model, when we gave endotoxin, the same dose of endotoxin that we gave IP or IV to the animals, when we gave it by our nebulization system, so we push it in the deep lung, look at the mortality in the animals. Almost all animals rapidly died. So by this load of LPS in the deep lung. And this was reversed by nanodexamethasone at higher level than by free dexamethasone alone. Not only we achieved higher concentration of dexamethasone by using nanodexamethasone, but also we found that we had higher biological activity. As you know, glucocorticoids, when they enter the cells, will bind to the glucocorticoid receptor, then the complex migrate to the nucleus, and in the nucleus will stimulate the expression of two major co-regulators who are DUSP1 and GILS. So GILS is used also as a way to assess the glucocorticoid activity of corticosteroids. So what we found here is that the expression of GILS was much higher with dexamethasone, with nanodexamethasone as compared to the free dexamethasone, while we were using the same dose of dexamethasone molecule. So highlighting that, again, there is improvement or increase in the biological activity of dexamethasone when delivered by a nanoparticle. And this is the same data for DUSP1 and GILS together. Looking at cytokine concentration in the BAL, in the bronchoalveolar lavage, again, downstream to activation of the NF-kappa-B, downstream of the inhibition of NF-kappa-B, signaling by glucocorticoids, we have a downregulation of a number of cytokines, and I no need to enter in details here. So the next step, because you know the mice and the small animals, lung function, immune cell function is really far from our own immune system and lung function. So it's very important before willing to move to test the nanodexamethasone in patients to go and see whether what we observed in the small animal could be observed in non-human primates, which immune system is very close to the human system. So we started, all experiments are still ongoing, but I can show you some preliminary data. So first of all, we had to set up a device that allowed deep distribution of a drug toward the deep lung. As shown here by imaging, one can see that indeed the nebulization of the nanodexamethasone is really delivering the drug to the deep lung. This nanodexamethasone then is associated with, again, a shift in the cells. So here there's a control situation for macrophages and neutrophils, and one can see the distribution here, the pattern of distribution of cells. When you challenge the animals with endotoxin, there is a clear change in these pattern for both macrophages and neutrophils. And when you add on top nanodexamethasone, you do not go back to the control situation, but again, you downregulated both the macrophages and the neutrophils. So we reproduced in the primate, the non-human primate challenge by LPS, we reproduce the immune effect that we have seen in the rodent animal. And now we are trying to move forward because we're not sacrificing the non-human primate. We now are moving and redoing all these analyses by a model of sepsis where the non-human primate is first hit by influenza, and then 2 days later by Staph aureus or streptopneumonia, and then animals develop pneumonia and sepsis, and we're now doing these experiments trying to see if we can indeed show in this severe pneumonia model in the non-human primate that the nanoparticle of dexamethasones provide mainly lung effects and minimum systemic effect, which is the purpose of precision medicine. Thank you very much for your attention.
Thank you very much for this interesting view on this. There is a question there, please, with the mic. I'm very happy that you start doing the bacteria pneumonia, because it's a big question, of course, whether the downside of the steroids or, yeah. So really looking forward to that.
Thank you, Gilles. I know your research program, but my question is, do we have any information on dose response?
Yeah, this is a very good question. And we started with the same dose of dex and the one you use IV. And as I have shown, the concentration reached in the lung are much higher with the nanodex, suggesting that we may very likely reduce the dose of dex delivered by nanoparticles. Yeah.
Okay. Thank you, Djillali. If there are no other questions, thank you very much.
Thank you.
It's a pleasure to ask to come on stage Patricia, Rocco from Brazil with the next talk.
Thank you, Maurizio. Thank you very much for the invitation to be here. And today I will try to do an overview of the pharmacological therapies. We listened during this afternoon how important it is to understand how the clinical trials were ongoing and how to change it. So I have no conflict of interest related to this presentation. While we know that ARDS is a syndrome and not a disease. And since 1967, when Ashbaugh and colleagues described the ARDS in 12 patients until now, the clinical trials on pharmacological therapies were based mainly in the pathophysiology. So we developed drugs, different therapies, in order to reduce the inflammatory process, the damage to epithelial and endothelial cells, as well as the matrix during the COVID, the increased pulmonary vascular permeability and then edema, oxidative stress, we heard about the vitamin C, and fibrosis. As you can see here in this paper that we published a few years ago, there are several clinical trials. I will focus not in preclinical study, because I thought that you expect, oh, she did several preclinical studies. No, I will focus on clinical trials. And as you can see here, several studies were performed using different therapies in order to reduce the inflammation and immune response, alveolar epithelial cell damage, edema and fibrosis, vascular remodeling, as well as endothelial cell damage, and pulmonary vasoconstriction and vascular permeability. Of course, we don't have time to talk about all these therapies. But what about inflammation and the use of corticosteroid? We know that during the first study, I know that all of you know about the high dose of methylprednisolone and no beneficial effect. And then at the late phase of ARDS, again, with smaller dose, no beneficial effect. So this is not the case of the dose or the moment that they decide to treat, because they thought at this moment that fibrosis concerning the pathophysiology occurs at the late phase. We know that it happened at the early phase. And the group from Jesus Villar decided to evaluate the effect of dexamethasone. Dexamethasone at the early phase of ARDS, and they observed an improvement in survival. But we have a guideline recently published in Critical Care Medicine, and they suggest that the use of steroids to adult to critically ill patients with ARDS, I will focus only in ARDS, present a moderate certainty. And they suggest that we can use dexamethasone at early phase, or even methylprednisolone with low dose, as well as methylprednisolone at late phase. Okay, corticosteroid may reduce mortality, moderate certainty. Longer course of corticosteroid showed better survival rates compared to shorter course. But all these other clinical parameters, as you can see here, fewer days of mechanical ventilation, short hospital and the ICU length of stay, neuromuscular weakness and gastrointestinal bleeding, low certainty or very low. Only hyperglycemia, they present a moderate certainty. So we have to do more studies. Probably the nanoparticle associated with steroids is our future, I don't know. And what about interferon? It was interesting that when I started studying interferon in preclinical studies, we observed a very good effects. And in the first clinical trials, they also observed better survival. But unfortunately, in the other clinical trials, no beneficial effects were observed with the use of interferon. What about the neutrophil elastase inhibitor? I know that there are many people from Japan and China here, and everybody, oh, it's approved in my country. Okay, they observed beneficial effects. But the problem is, pathophysiologically speaking, it seems to be good, because elastase destroys the endothelium and reduce the increase the inflammatory process. So if you reduce the elastase inhibitor, seems to be good. And there are many papers published using this drug, and unfortunately, this one showed, and the design is very good, no beneficial effects with civilistat. Okay. We don't have evidence to date, even though there is a paper published now in 2014, 2024, showing it's safe. There are several controversies. Okay. Don't use it till now. What about the statins? The statins reduce cholesterol. How is the mechanism of statin? Reduce neutrophil migration, and then we have an improvement in the inflammatory process. No more inflammation. And reduce edema. Okay, but again, no beneficial effect. When we use all patients, all ARDS heterogeneous patients with simvastatin, no beneficial effects. What about rosuvastatin? Everybody loves rosuvastatin to reduce cholesterol, but no beneficial effect again using rosuvastatin. Wow, we have to do something. And then they decide, oh, since we have these changes in the hyperinflammatory, let's see it using low cholesterol patients. Let's do a secondary analysis of HARP2 with simvastatin and sales with rosuvastatin. This paper was published now in 2023 or 4. And okay, why they decide to do so? Low cholesterol is associated with increased mortality in critical care patients. And they observed that when they analyze patients with low cholesterol and rosuvastatin, the mortality, it's incredible, increased. And when they associate with simvastatin, even though it's written that mortality reduced, the p-value is not significant. So it's not the problem of cholesterol that induce a severity or not, or a response or not with simvastatin. What about the beta agonist? I remember that I started some preclinical studies with beta agonists more than 20 years ago, and I was so happy because the answer was amazing, because we inhaled, because we injected, reduced the inflammatory process, but no beneficial effect. Even the survival reduced with the use of beta agonists, so please don't use it. And what about edema? Everybody tried to reduce the edema in ARDS patients. And we know that corticosteroid, since we reduced the inflammatory process, we try to heal the epithelial and endothelial, reduce the edema. But they decide to use surfactant. And believe it or not, there are several ongoing clinical studies using surfactant in 2024 in adults. And they use the 2 different types of surfactant, exosurf, calfactant. Again, nothing happened. And what about the pulmonary vasoconstriction? I will focus on nitric oxide. Okay, we know that increase the PO2, increase oxygenation, it's very good, no problem. In contrast, nothing related to beneficial effect concerning the mortality rate. Again, nitric oxide, no reduction in mortality. And we have to pay attention because it was associated with an increase in incidence of renal dysfunction. Okay, they decide to do a guideline. Now we have guideline for everything, so for every drug, every therapy. And they observed, okay, we can use before using ECMO, only to increase the PO2, FO2. Yes, we can do it. And what about the vitamin C's and D in ARDS, okay? I will talk about the reduction in the risk of ARDS. Before the induction of ARDS, nothing happened. No beneficial effect with vitamin C or vitamin D, even though we have clinical trials ongoing trying to evaluate vitamin C and vitamin D. And aspirin, Several of you, aspirin is a solution for cardiovascular problem, even to respiratory problems. And again, 325 milligrams of aspirin. It's a solution for preventing ARDS. No beneficial effect. And what about the nebulized heparin? Wow, it seems to be good. In these clinical trials, they observed that to reduce inhaled heparin, reduce the risk of ARDS. So there are some ongoing studies in ARDS and trying to analyze the beneficial effects or not of heparin. And what about other therapies? Of course, I love mesenchymal stromal cells. I have been working with these cells in the last 20 years. And the rationale is based on anti-inflammatory effects, antifibrotic effects, the repair of epithelium and endothelium. So it seems to be a magical drug, a magical therapy, it's not a drug. And the group from Michael Mathai decided to focus on this therapy. And they evaluated different number of cells. And they observed that we need to inject a high number of cells to have a beneficial effect. And here they observed that there was a reduction in lung injury score. So they decided to do a clinical trial. So let's see whether or not these high number of cells may induce a beneficial effect and not embolism. And multi-center, randomized, double-blind, placebo-controlled trials, what happened? Nothing. No beneficial effect concerning the mortality. And then the group from Miami decided, no, let's try to use other cells. Now I'd like to use the multipotent adult progenitor cells. And they decided to perform 3 cohorts to evaluate which was the best dose, and then to evaluate a clinical trial, a randomized control trial. No beneficial effects. And more recently, the Realis orb cells were published. This clinical trial was published in Blue Journal. They focus on oxygenation. In ARDS patients, what happened? Nothing. So, I don't know if we have to stop or if we have to move forward trying to homogenize these patients, such as we have to do with the other drugs. This is my last drug, this is atracurium. We know that in addition to perform a protective effect concerning the inflammatory process, because it reduces inflammation. In this first trial, they observed that cisatracurium reduced the mortality in very severe patients. However, in the ROSE trial, no beneficial effect concerning the mortality. We published this review recently, and we discussed a lot this subject during this review. Well, first, we don't need to use as a routine the use of neuromuscular blocker agents. Second, probably in cases of asynchrony or in placing prone position, sometimes a little bit difficult to put the patient in prone position, we can use it. So we are facing a therapeutic challenge, and I don't know the answer. But I know that if we're still using in a clinical trial patients with pancreatitis, pneumonia, sepsis, and trauma, we will spend a lot of money and nothing will happen. Okay, all these drugs, no beneficial effect. We have to focus probably in personalized therapy. We have to change We know that focus on drugs, according to the pathophysiology, probably is not the future. Preclinicals indeed show benefits, but I usually perform preclinical studies as well as clinical studies, and then I know that we have to do a model that indeed resembles ARDS, not only endotoxin, but we have to focus on this issue. We have risk factors associated with these patients. Personalized therapy targeting different subphenotypes probably is the future. Identification of ARDS subphenotype is required when selecting patients for clinical trials. I'm working with proteomics, transcriptomics, and probably this is the future, but I know that's so expensive. I know that future trials need to focus not only in the pathophysiology, but also in biomarkers, also in comorbidity risk factors. The investment of personalized therapy, this is a very important issue, is too high, requiring both personnel and resource that's not so common in ICU. So thank you so much for your attention.
Thank you, Patricia. We have time only for one quick question or comments, because I know you're going to chair a session in another room. But I have a comment, but I would like you also to comment. Do you think that we really should change completely the way we do studies in intensive care on drugs, in the sense that if we really want to go and find this selective group of patients with similar phenotypes, probably it's impossible to do it with the current networks of ICUs, and we should really think about getting together with very large groups of ICUs, screening patients together, and then going for very, very precise, maybe small trials where we randomize on specific phenotypes?
Yeah, I know that to use this heterogeneity, it's not a solution. To add all these patients, it's not a solution. We are dealing with the proteomics, metabolomics, and we are observing that, for instance, the case of metabolomics that was recently published now in 2024. And we observe, for instance, some important difference between viral pneumonia and bacterial pneumonia. You see, different biomarkers. And when we focus on inflammation, we are dealing with trauma that there is a proteomic and metabolomic completely different from abdominal sepsis, pancreatitis, and pneumonia. So I think that if we are still doing the clinical trials as it is, we have no future.
I agree. Thank you very much, Patricia.
Thank you very much, Professor.
So I would like to welcome the next speaker, Joe Garcia from Florida, about a new antibody in ARDS.
Yeah, thank you, Mr. Chairman. Appreciate the invitation to be here. My name is Skip Garcia. I'm a critical care and pulmonary medicine physician scientist, and like many of the scientists and physician scientists in the crowd here, the holy grail for us is, of course, finding a discovery in the laboratory that we can bring to help patients in our clinics or in our ICUs. Well, I'm going to be telling you a journey for this physician scientist. And in addition to that goal, my goal for this next year is to stay off of Dr. Rocco's slides of non-beneficial methodologies and trials that have taken place. So with that, let me just go. So I'm the CEO and founder of a company called Aqualung Therapeutics. And the seminal observation that underpins this company and the talk today came out of my lab when I was Chief of Pulmonary and Critical Care Medicine at Johns Hopkins University. And the discovery in my lab was that we identified, using genome-wide expression profiling techniques, we identified a very novel gene that encoded a protein called ENAMT. ENAMT is a damage-associated molecular pattern protein that we have identified, and it does that by binding to that pathogen recognition receptor known as toll-like receptor 4. And in eliciting that TLR4 inflammatory cascade is involved in multiple inflammatory process. And when it's secreted or released into the blood from pyroptotic pathways or in response to tissue injury, it activates the TLR4 signaling cascade to regulate innate immunity-induced inflammation and fibrosis. And that's not just in the lung, it's in multiple organs. And of course, we've identified and generated a humanized monoclonal antibody. It's called ALT-100. This antibody binds to ENAMT, neutralizes ENAMT, and forms the basis for a clinical trial that we are now undergoing. It's called PORTA. And PORTA is a moderate severe ARDS trial where we're using ALT-100 as a mitigating therapeutic. So the way we identified this protein and gene initially is that we were using, as I mentioned, genome-wide association of dysregulated genes using mice, rat, and pigs exposed to LPS and to the ventilator-induced lung injury. And we identified pathways and genes and new novel targets. And among these novel targets is the protein I'm talking about today, which is NAMPT or NAMPT. When we first identified NAMPT, there was only 8 papers in all the world's literature. 4 of them were in the OB-GYN literature. 4 of them were in the immunology literature. None of them were associated with lung inflammation, lung at all, or injury of the sort. And what we identified since that point is that this is like many other damage-associated molecular pattern proteins, it has a very important intracellular function as a regulator of NAD metabolism. The NAMPT stands for nicotinamide phosphoribosyl transferase, so it regulates NAD levels in cells. But what we also, and very importantly, showed is that when this protein is released from cells, it functions as a damage-associated molecular pattern protein to activate the innate immunity inflammatory cascade by binding to toll-like receptor 4. In our models, our preclinical models of ARDS and ventilator-induced lung injury, we showed that endothelial cells, as shown here on the left in this canine model, or leukocytes, are also very prominently expressing NAMPT in response to ventilator-induced lung injury. So I would say that, we've used polyclonal antibodies to show that targeting this protein was very effective in mice and rats. But I would say there's 3 key observations that that we have that support ENAMPT and TLR4 targeting in human ARDS. And the first of these observations is that we can measure ENAMPT in the blood. It's a very, very robust biomarker that is elicited and found in patients with ARDS that's due to either sepsis or trauma, including acute pancreatitis. And importantly, the levels of ENAMPT in the blood also correlate significantly with severity of disease, as shown here in these 2 different studies that we have published. The second observation that I think is very important for us to link our targeting of NAMPT to human ARDS is the fact that we've sequenced the gene in several cohorts of ARDS patients. We identified 4 polymorphisms in the promoter of the NAMPT gene, and we first reported that these SNPs in the promoter of the NAMPT gene are highly associated with risk of developing ARDS, and several other groups, including the paper here by David Christiani's group at the Massachusetts General, showed that not only was associated with the risk of ARDS, but also the severity of ARDS. And more recently, we've shown that these SNPs that are shown in the slide here, the mechanism by which they contribute to that risk is that they regulate the amount of ENAMPT that is transcribed and released into the blood, and therefore drive ARDS severity. Then the last observation that leads us to conclude that this may be a very important and relevant target for ARDS is that we took PBMCs from patients with ARDS. I divided in those who survived and didn't survive at day 0. And we, looking at differentially regulated genes, we identified 3 key pathways that were associated with survival or lack of survival. And the most important, the top dysregulated pathway was the toll-like receptor signaling pathway. And just to recall that ENAP binds to toll-like receptor 4. So we've generated this antibody, we've expressed it, we have plenty of drug to do our clinical trials, and we have really good expression profiling. It's an IgG4 humanized monoclonal antibody, and this allowed the FDA to give us the green light to go ahead and proceed with our PORTA study that I'm going to talk about in a second. But we've also used this antibody in mice that have been on the ventilator with LPS, rats that have been challenged with LPS on the ventilator. And it's important for me to tell you that this antibody doesn't block toll-like receptor 4. It's not a TLR4 inhibitor. The antibody blocks the ligand for TLR4, which is ENapt. And when the most, I think, compelling data I can share with you from these kind of studies is data we were able to generate in a porcine model of ARDS. And in this model, we take Yucatan mini pigs, give them septic shock and ventilator-induced lung injury for 12 hours. As you can see from the panel on the bottom there, that histological sections of these pigs after 12 hours of septic shock and villi are quite dramatic. If we take a similarly challenged pigs and give them our antibody either at 2 hours or 6 hours after the start of that injury, you can see there's a very dramatic reduction in inflammatory injury. And this is associated with reductions in cytokines and lactate levels, et cetera. One of the reasons that I think, personally, that I think our drug has a really good chance of working in human ARDS trials is really in this Western blot. In this Western blot, we're looking at a readout for innate immunity activation, which could come from any one number of cytokines, as the audience well knows here. It could come from TNF and IL-1, et cetera. The three middle panels there show that there's very prominent NF-kappa B phosphorylation indicative of innate immunity activation. And on the far right, you can see that the antibody essentially abolishes this activation, suggesting that this ligand activating this pathway may be very relevant to this model of sepsis-induced ARDS. So additional data that you can get and achieve from this particular type of model, we know that the ALT-100 monoclonal antibody reduces lung water imbalance. We used ultrasound generation of B lines and showed that the dramatic increase in B lines after 12 hours of septic shock and villi is attenuated by animals receiving our antibody at 2 or 6 hours. And this translates, as you might imagine, into a reduced lung stiffness as reflected by a time-dependent and significant increasing of the static and dynamic respiratory compliance. We also, very importantly, for any drug that will likely be effective in moderate to severe ARDS, we've demonstrated that ALT-100 also reduces renal injury in this model. The advantage of the model is you can identify very strong indices of renal injury, like increasing lipocalin, which you see here, that is reduced by our monoclonal antibody. And if we examine the histologic nature of the renal injury in these animals, there's very strong evidence of necrosis in the renal tissues and of tubular dilatation. And in animals receiving our ALT-100 antibody, either 2 hours or 6 hours after the start of that injury, they look very, very similar to the baseline renal histology. So we've used this antibody in phase 1 trials. We conducted these in Brisbane, Australia. 4 doses. We had 0 serious adverse events. The adverse events we saw were very similar and not significantly different from placebo. We've performed our pharmacokinetic studies with this antibody, and importantly, there's a dose-dependent increase in the half-life of the antibody, and very important for our PORTA study, because we're given the antibody only one time in a single dose in the PORTA study. It's because the 0.4 milligram per kilogram dose has over a 2-week half-life, and the 1 mg per kg dose has over a 3-week half-life. So this is our PORTA study. We're targeting moderate to severe ARDS. The exclusion, an important exclusion, is we're not entering COVID patients with COVID. But moderate to severe ARDS using the new ATS criteria of either P to F ratios or the saturation divided by FiO2 ratios. We're taking patients that are almost immediately intubated, patients with high flow, or patients with non-invasive. We randomized them to initially to the first dose, which is the 0.4 mg per kg at a 2-to-1 ratio, and then the second cohort kicks in after that's deemed to be safe. And then we'll have an interim analysis of these first 18 patients and looking at specifically safety objectives as well as efficacy objectives, which are very similar to just about every other ARDS study that's ever been conducted. Based upon these data here, we will then move into a dose expansion phase on a 1-to-1 basis using a single dose that's determined by the Data Safety Monitoring Committee as being safe. Now, I think what's a little different from our study than other studies is that we are administering this drug within 4 hours of their intubation. This is a very challenging aspect for those of you conducting the ARDS trials, but we have 4 hours from the time the patient's intubated to randomize them to deliver the drug, or in the other two groups that are non-invasively or high-flow patients to randomize them at the end of a 12-hour period. They have 12 hours to be randomized. So we have 12 sites in the US, 2 in Australia that are part of our study, and we have 5 patients currently enrolled. The last 4 sites in the US are now coming on board right in the next couple of weeks, so we're anticipating enrollment to really ramp up. And we're very excited about where we are and the type of study that we have engaged. So the only last 2 points I wanted to make have to do with something that's been talked about, several times during the course of this symposium. The first speaker spoke elegantly about the hypo-inflammatory and hyper-inflammatory phenotypes that are very important. In analyzing the number of patients that are in the hyper-inflammatory category, many of them, but not all, start out in moderate to severe ARDS. So we may have an enrichment of the hyper in our group, but it's not unanimous, which is a little bit troublesome, but we'll see how we do. But another important point of this paper that just came out a few weeks ago, again by Karen Calfee and her group there, is that the vast majority of the hyper-inflammatory folks died within the first week, and many of them died within the first 48 hours, really highlighting the need to start these therapies as early as possible. And the second point that I thought was interesting out of that paper is that they took PBMCs out of these ARDS patients. This is from the Petal-Rose trial that was conducted. And they did differential gene analysis and pathway analysis. And at the day 2 levels within the hyperinflammatory group, what they found was that, increased dysregulation of these pathways, which are all collagen and fibrosis regulatory pathways, were found to be indicative of a worse response to the ARDS exposure. And why is that important for us? Well, I think it's important because we know that from our preclinical studies that the ALT-100 antibody is extremely effective in mitigating lung fibrosis. And we have this as our primary chronic indication is to reduce the severity of lung fibrosis. We've shown this preclinically in radiation-induced lung fibrosis. We more recently showed this in bleomycin-induced lung fibrosis. And we've showed specifically that the antibody has a very strong effect on reversing endothelial and epithelial mesenchymal cell transition, which is a key part of the fibrosis pathway. So in finishing here, I just wanted to say that the way we've designed this study is to really address at least 3 aspects of why clinical trials in ARDS and sepsis have failed. One was that, that many trials previously used only data generated from LPS challenged mice. We have used LPS and ventilator-induced lung injury exposed mice, rats, and large animals, which I think is an important aspect of our trial. Secondly, we're giving the drug very early in the course of their ARDS, within 4 hours of intubation, within 12 hours of the diagnosis of moderate to severe ARDS, so that addresses another problem for prior studies. And then finally, the therapeutic targeting. We think we're targeting a very upstream ligand of the inflammatory cascade, ENaMT and TLR4 signaling. So I think that we have a check mark on each of these. The last point is that because we have genotyping and because we have a biomarker, I think we're perfectly positioned for a precision medicine approach in the next phase where we get a good answer from our phase 2 trial. So with that, I'll stop right there and happy to answer any questions. Thanks.
Thank you very much. Are there questions from the floor? Waiting for the questions. Well, I have a practical question. So the 4-hour time window is really brief. Do you work with deferred consent, or how do you approach it?
We're doing that for sure. It is challenging. There's no other way to say it. You know, the response by each of the research coordinators at the sites that we've enrolled was panic, of course. But I think it really dictates this important, seamless transition between the ICU and the emergency room, right? If you can identify those patients quickly with electronic alerts, and we're going to very much electronic motifs to try to address that. Very much close in with the ECMO alerts and the sepsis alerts, so we can identify these patients, sign them up before they develop to moderate to severe ARDS, and then follow them as they evolve into which many of them will not, but that's okay. We want to make sure that we get onto them early.
Okay, so you approach them already before, yeah, okay, cool. Other questions? So another question, the animal models you already have done, it's LPS, it's Philly, it's beautiful. Do you also already have bacteria-induced ARDS animal models, and how did it look like?
Yeah, we're doing that as part of some multi-drug resistant trials that we're undergoing right now. The only other live animal that we did were MRSA that were killed. So we didn't use live bacteria in that study either.
Because it would be interesting to see whether it, And the other thing is drug antibodies. Have you measured them, and do they develop? Because you want to give it chronically, so for the long term it would be interesting to know.
Yeah, that's a great point. We didn't see ADA developed in our healthy human volunteers. We think it won't be a problem with our ARDS trial because we're only giving it a single time. But for the other indications, the chronic indications, you're absolutely right. We are very keen to know what the ADA development is in those patients.
Okay.
Great. Fantastic talk.
Great,
Thank you. So, last but not least in this session, Professor Frank van Haren from Australia with the last talk of the day.
Thank you, Mr. Chairman. Thanks for staying. The first thing I want to say is that I was so relieved when Patricia Rocco was ripping apart all these drugs on her slides, that there was one drug on there, inhaled heparin, that she didn't pull apart, and she left the door open a little bit. And I just want to talk a little bit about nebulized heparin and where are we at with nebulized heparin? Is there any signal that this could potentially be used for ARDS in patients? So I have no relevant disclosures for this presentation at this time. So why would we try inhaled heparin? I mean, the previous presentation was about a very targeted, super clean, really well-researched drug. Heparin is a dirty drug, right? It's dirty. It has many, many different effects, and it's very hard to know which effect is useful in patients with lung problems. So heparin has been obviously used for a long time, mainly for the anticoagulant use, but inhaled heparin has also been used for more than 30 years now, mainly in asthma and COPD. There's been a couple of studies, I'll show you in a second, that show some effect on lung function in patients with COPD and asthma, and also a couple of other indications. And it's also a cheap drug, rather than and this, I guess, is, and there's no criticism, but this, I guess, is a different approach to developing a super expensive drug that will only be available in sort of high-income countries. We thought that if we can do more research with heparin, heparin is available in every sort of fridge in every low and middle-income country, so we might be able to have a product available for everyone around the world very quickly if this drug works. So. Some data from a couple of years ago from Professor Shute from England and also with Clive Page, one of my co-workers from the UK. Patient with moderate to severe COPD, they gave inhaled heparin versus placebo and looked at lung function improvements and exercise capacity. And the lung function improved sort of over the first week, and that was in a sustained improvement after 21 days in patients. Again, this is not really my topic, but I just want to show you that there is actually quite a bit out there looking at inhaled heparin in patients. And a recent meta-analysis published last year of mainly small studies looking at asthma and COPD, with a primary outcome mainly lung function, which is relevant for these patients, showed a statistically significant improvement in lung function. And I only show one of them, but there's a bunch of lung function parameters that were measured, and they improved, including fatigue and a couple of other things. So heparin is a dirty drug. Heparin does lots of things on the coagulation, as we know, on the clotting cascade, the fibrinolytic, but heparin, and this is what most people probably don't know, is also a strong anti-inflammatory drug. It has direct effects on white cells and how white cells and platelets bind to the endothelium. It has an effect on how macrophages are activated, and it has direct, and I'll show that in a second, direct antiviral and antibacterial effects, which may also come as a surprise to you. So to show this, I'm just using the COVID lung injury as a model, also because I already had these slides, so it's much easier to put that in this talk, but it will it will sort of give you the same, I guess, viewpoints, because a lot of this is similar in ARDS, just to slightly different extents. I would argue. So, well, the first point, of course, is that COVID needs to enter the cell. I know you're very tired of COVID, but bear with me. It uses the ACE2 receptor to enter the cell, and that immediately gives the first bit of lung injury by hijacking that receptor and causing vasoconstriction and lung injury. So that's the first step. And then once COVID has entered the cell, there's a bunch of things that happen. And again, a lot of this happens also in other ARDS, so this is not just unique to COVID, but there is massive activation. I'm not sure if you can read it from the back, but fibrin activation both in the microvasculature and also in the alveolus. And those fibrin strands will then attract neutrophils and create the hyaline membranes that we see in ARDS. And there's microvascular thrombosis. Now, I'm sure you've all seen this slide. It's an old slide, but I always like to sort of show it. This was a rat model of streptococcal pneumonia, and you can see under the electron microscopy those fibrin strands entering the alveolar cells and then binding to these white cells, where then your hyaline membrane is formed. In terms of coagulopathy, COVID ARDS had, as we know, much more coagulopathy and microvascular thrombosis and PEs, but non-COVID ARDS also has microvascular thrombosis and coagulopathy. So the other thing COVID does is it will activate the macrophages, the neutrophils, and create a bit of a cytokine storm locally by releasing all these inflammatory mediators, and also the creation of these neutrophil extracellular traps, the DNA nets that have all these cytotoxic sort of elastase and free DNA that causes more lung injury. So this is all important part of the pathophysiology of COVID, but also of lots of other types of lung injury. So how could heparin have an impact on any of that? And the hypothesis is that, first of all, heparin has an antiviral effect. Now, that's no longer a hypothesis. That's now been proven. I'll show that in a second. To understand how that works, you need to know a little bit more about how these viruses enter the cell. And in fact, our body has heparin, obviously, in mast cells, but also most of the heparin that's inside our body is part of the heparin sulfate, which sits on the cell membrane. And that's a really weird molecule. It's this long, wavy molecule. It looks a bit like a mop, and it actually acts as a mop. So when a bug comes by, it will mop up that bug and present it to the receptor. So you need that presentation by heparin sulfate to the ACE2 receptor for the SARS to enter the cell. And that's not just for SARS, but it's actually also true for a whole bunch of other bacteria and viruses. This is how these bacteria and viruses infect and enter our cells. So they use the heparin sulfate. So if you then give heparin, which sort of is a similar molecule, it literally mops away the microorganisms. So this was work from Public Health England that was done early on in the pandemic, where they showed in cell cultures that unfractionated heparin has a very, very strong antiviral effect on COVID, and much, much stronger, for example, than a low molecular weight heparin like Clexane. And this since then has been shown by multiple groups around the world. So it might stop entering the cell. And then heparin has these other effects that I briefly mentioned on coagulation, on inflammation, and DNA nets. And all these effects have been shown to a certain extent in preclinical work. So early on, we published this paper and said, well, look, there is a signal, maybe, and there is some rationale, we should test it. And we summarized the evidence for heparin as a treatment for lung injury until then. And surprisingly, and you probably can't read the table, but it's not relevant, but the point I want to make is that there's actually quite a lot out there already in terms of preclinical work, animal work, that all points in the same direction. When you inhale heparin in all sorts of models of lung injury, you reduce that pulmonary coagulation problem, you reduce the pulmonary inflammation, and there's an improvement in oxygenation in all these models. What about human studies? So a phase 1 study done by Barry Dixon in Melbourne, in a small study of patients with lung injury. So he did BALs in these patients, and he found that a couple of these pulmonary coagulation markers significantly reduced with the use of inhaled nebulized heparin. And since then, there's been quite a number of phase 1 and phase 2 studies looking at nebulized heparin for lung injury. They all, again, this is a table that you can't read, but you can find it in that original review paper. They all point in the same direction, where if you inhale heparin, you have an effect on the coagulation problem in your lung. You reduce dead space. There is an improvement in lung injury scores in some of these studies. And 1 or 2 studies also showed an increase in the days free of mechanical ventilation. These are all small studies, but there's a bit of a signal that, it might work. So this is the paper that Patricia Rocco showed as well, led by Barry Dixon. So we did a randomized controlled trial, double-blind, placebo-controlled, inhaled heparin versus placebo in patients with ARDS or at risk of ARDS. And what Patricia already showed on the right for you, is that patients who were at risk of ARDS had a lower number of patients than developing ARDS when they received nebulized heparin compared to when they received nebulized saline. On the left, there is a depiction of the Murray lung injury score, and patients who received inhaled heparin in this study had a significant improvement compared to the placebo group in their lung injury score, and much quicker. Now, the primary outcome of this study was functional recovery, so after 60 days, using the validated tool SF36, and you can see that there was no difference between the two groups when you look at sort of the mean or the median of this distribution, but you can see that the distribution is quite different. And when we looked at it again, when you compare the patients who have a very low score, so have very poor function, there's many, many more of these in the placebo group than in the heparin group. So, this is post-hoc analysis, so it doesn't mean much, but there may be a signal there that there's an improvement in physical function of these patients when you look at the distribution rather than the mean of this primary outcome. Then during the pandemic, we published this case series for nebulized heparin in COVID-19, and these were patients, it's uncontrolled, 2 centers in the US and 1 in Argentina, who decided on the basis of the existing evidence who decided to give heparin to patients when they had no other, other treatments available for them. So uncontrolled, and we collected the data in a standardized way. And we published this paper mainly to show that it's safe in COVID-19 patients. So inhaling high doses of heparin does not have a significant effect on the APTT, so it does not have a significant effect on systemic coagulation. And in this case series, almost half of these patients were on therapeutic anticoagulation already, either Clexane or heparin. So adding inhaled heparin did not have an impact on the APTT, and there were no significant complications in terms of bleeding. So it was mainly a safety publication, but we did have some exploratory analyses of oxygenation. And remember, these patients, it's uncontrolled, but these patients were worsening. The clinicians didn't know what to do and decided to give this, this drug, this heparin, to see if they could improve these patients. And when you can see the oxygenation, this is the SF ratio before it was given, and then after heparin was started, you can see that there's an improvement in oxygenation. Again, there's no control group, so maybe this would have happened without doing anything, but looking at the trend, there may be a signal there, and this is a different way of looking at this. When you look at the FiO2 in these patients, it was going up, up, up. They decided to give heparin, and then the FiO2 started to come down. Again, no control arm, so we have to be very, very careful interpreting these details. We then did a small RCT in Brazil, funded by the UK, in only 76 patients. We were going to recruit many more, but then in the centers that recruited patients, there were essentially no more COVID patients coming in, so we had to stop the study. We used a vibrating mesh nebulizer. These were patients not intubated, but we were trying to give this early to improve their clinical situation and reduce the number of intubation. Now, this was obviously not powered for mortality. There is no difference in mortality. There is a modified intention to treat analysis that you have to be really careful with, I think, because it excluded patients who died within 24 hours, and it only allowed patients to be in the analysis if they had at least 4 doses of heparin. The idea was that if you try and show that heparin works and the patient didn't actually get heparin, it's very hard to have an effect. So this is sort of a post hoc analysis, again, exploratory. I wouldn't say that this has an effect on mortality. There's no effect on mortality in this study, but there is a signal maybe, and certainly no harm. There were a couple of other outcome parameters that we looked at in terms of the WHO scoring system for COVID-19 that improved as well. Now, this study is part of a larger study, so we have been working together with people around the world who all did studies with inhaled heparin and combining them into a meta-trial. And this meta-trial has now finished. All the sites have stopped. We have just over 500 patients. I was very hopeful I could show you the results today, but I'm very sorry I can't. Don't cry. But there is, just looking at the data, there is a signal in the right direction, but we just have to wait for the formal, peer-reviewed publication that we're working on. So this was a study in patients who are not yet intubated to try and prevent intubation. We did a similar meta-trial in a couple of countries in patients who were already intubated to try and get them off the ventilator quicker. And that it has also stopped, and we're about to analyze that. That's a much smaller sample. We only have between 100 and 200 patients in that meta-trial. So to conclude, there is a rationale, biological, to look at heparin. But as you've seen from Patricia, Rocco's presentation, that doesn't mean anything. You can have a fantastic rationale for statin, for aspirin, for all these drugs, and then when you start testing it, it has no effect. So yes, it has a rationale. Yes, we know from preclinical data, animal studies, and early human studies, we know how it works. We know it works, to a certain extent. But whether this then translates into useful clinical outcomes for patients is unclear. So we have some data that's supportive, and that's why I think Patricia left the door open and she didn't rip it apart completely. There are some positive studies, and we just need to wait for the meta-trial results, and then we can take it forward, because the meta-trial is also not going to be a definitive study. You know, it's a combination of a bunch of different studies that have slightly different methodology, so it's quite messy, but it will still either give a signal or no signal, so we'll have a bit more to work with after that. And with that, I thank you.
Thank you, a great lecture. Any questions from the floor? Yeah, there is a question. Microphone is coming.
Great presentation. My question is there any place for other anticoagulants for nebulization, as for example antintaurin 3 or others? And the second question is the combination of therapy.
Yeah.
Because after the Patricia presentation, etc., probably is necessary to combine different treatments to try to improve the outcome of these patients.
Just also to add, his conflict of interest is that he's on the executive committee of the meta-trials, so he knows what he's talking about. He's one of our co-workers, of course. Yes, there is definitely biological plausibility and rationale for some of the other anticoagulants. They all have different effects and different, and as I said before, heparin is not a clean drug, it's a dirty drug. It has so many different effects, which makes it very hard to know, what part is important. And if you translate that, for example, to low molecular weight heparin, the antiviral effects for low molecular weight heparin are not as strong as they are for unfractionated heparin. But there's other studies that looked at low molecular weight heparin inhalation that also have some effect on some of the outcomes that were measured in those studies. So I think there is, it's quite a big field. There's a couple of other candidate drugs, I think, and there's also some drugs that have been developed to be more clean and have a much more clear distribution in the lung. What I didn't talk about is that when you inhale heparin, you also need to know how much actually goes into the large airways, how much goes into the deeper airways and into the lung. And that's different when you use different nebulization techniques. So vibrating mesh nebulizers are quite different from jet nebulizers. So there's a whole bunch of different factors to consider. Combination treatment, yeah, I think so. I think there is a role for combination treatment. We just need to do the studies, the preclinical studies, and then see if there's any, any benefit in putting it out to clinical studies.
Thank you. So we come to the end of the session on